Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the MOG's Endocrinology Committee, and a very warm welcome to all of you, assembled dignitary and faculty, as well as our audience who are here today for this program on high-risk pregnancy. Today, we are privileged to have with us five different societies, including the Dindigal, Karimnagar, Pondicherry, Tirunelveli OBGYN societies from the south, and my co-convener for today's program is Dr. Charmila from Trichy. Welcome, ma'am. We'll have a formal introduction in just a couple of minutes. Can we have the next slide, please? I always like to start all our events by expressing my gratitude to both my president and secretary of AMOGS. Our president, of course, is very well known. Dr. Nandita Palchetkar is a past president of FOXI, immediate past president, and is the current president of AMOGS. She's very well known, and what is even better known is that she's all for academic activities and spreading the light of knowledge. And every time I call her up and say, "Ma'am, we are doing this program," she'll be all gung ho about it. Please go ahead, do as many as possible. She's always welcoming and supporting us in all our endeavors. Next slide, please. My association with Dr. Arun Naik again also goes back several years, more than a decade, I would say. And sir has always been a guiding light to all of us juniors from the Mumbai Society. He is a past president of the Mumbai Society, of course, and now he is the secretary of MOGS. Thank you so much for your kind support all the time, sir. Sir cannot join us today, unfortunately, because he is stuck in a postgraduate exam, but I'm sure he sends us blessings and good wishes. Next slide, please. To formally introduce my co-convener for today's program, Dr. Charmila. She is actually an alumnus of Grand Medical College in Mumbai. So she is one of us, so to speak. She is the chairperson of the Clinical Research Committee of FOXI from 2016 to 18, president of the Menstrual Hygiene Management Consortium, joint treasurer of the Indian Fertility Society Tamil Nadu chapter. She has her own fertility center in Trichy, also a consultant with the Southern Railway Hospital in Trichy. She's won several prizes and awards, both individual and society prizes. She's won 5 trophies of FOXI as the secretary of the Trichy OBGYN Society, organizing secretary of Yuva FOXI South Zone in 2013. And there's one thing which both she and I share in common. Both of us have won the FOXI Dr. Merudara Hansotia Prize for the Best Committee Award. She won it before me and I won it after her. A warm welcome to Dr. Charmila. And between the two of us, we will proceed to introduce the chairpersons for today's program. Can we have the next slide, please? Dr. Charmila, you need to unmute yourself. Yes, please.
Good afternoon to all. It's a great privilege to be with AMOGS again and with Dr. Pratik Tambe. I would like to welcome the president of AMOGS, Dr. Nandita Madam, who's very dear to us even in South, because she's a very endearing personality to many of us, and the secretary of AMOGS, Dr. Arun Naik. And I would like to thank Dr. Pratik Tambe for such intensive programs that he arranges, and all with academics. And that's a great privilege that you're able to join your program. And I would like to welcome the chairpersons, Dr. Parag Pimbiniwale, another person who's very dear to us. He's from Pune. He's a unit head and PG teacher from Kamala Nehru Hospital, the secretary of ICOG, the president of the Menopause Society of Pune. Now, he's been the national secretary of IMS. He's been a website editor of FOXI in 2011 to 17. He's a peer reviewer of Journal of OB-GYN of India. He's been the chairman of the Young Talent Promotion Committee. He's been the master trainer of adolescent-friendly health services. He's conducted several workshops for WHO, UNFPA, GO, and FOXI. He's the co-editor of the one book that's on gynecological manual on adolescent girl and young women. In the yearbook of obstetrics and gynecology, he's contributed several articles to books and journals, delivered so many orations and guest lectures in almost 120 FOXI societies. He's a recipient of the Dr. C.S. Dawn Prize in the 51st All India at New Delhi in February. I would like to welcome Dr. Parag.
I think Parag is in transit from his clinic to home, and he will log in and share his words of wisdom with us shortly. Can we have the next slide, please? We have with us Dr. Arun Madhav Borua. He's a consultant gynecologist from Sampriti Hospital, chairperson of the Northeast ISAR, home and he will log in and share his words of wisdom. There is an audio echo. Somebody needs to switch off their device, please. We have with us backend team. Please mute everybody else. Thank you. Dr. Arun Madhav Barua is the organizing secretary of AICOG 2010 in Guwahati. He has several publications to his credit, including chapters in various textbooks and recent advances. He is a graduate of the Assam Medical College in Dibrugarh, and just a couple of weeks back, we had a very wonderful program in Dibrugarh where we had some stalwarts with 30-40 years of experience, and I think one of sir's own teachers was there for the program. It was wonderful to see all of them. I think probably if we had not had lockdown, this is one of the positive things I can say that we can take from the lockdown that we have had. That thanks to this, we are able to connect with so many eminent personalities who we would not normally see at physical events. Sir is a member of probably more than 20 organizations, and I can say that he's a very well respected figure. He's also a candidate for the vice president election of Foxy from the East Zone for this year, and we wish him all the very best in his endeavors. Can we have the next slide, please?
It's my honor to introduce one of the senior most obstetricians in Tamil Nadu. She's considered almost like a Bhishma for us, Dr. Amala Devi from the Dindigal Society. She joined medical services in 1972 and retired as project officer and joint director administration of the Department of Family Welfare in Chennai. And she has conducted so many programs for us in adolescent work as well as menstrual hygiene work, and extremely thankful to her for that. And just won so many awards, a State Secretary Appreciation Award and the State Secretary Appreciation Award from the IMA, as well as for the individual contribution to IMA. She's a very active member of IMA Tamil Nadu. She has won the Dr. Abdul Munaf Best Writer Award and the State Secretary Appreciation Award for Tamil contribution. She's a wonderful Tamil writer and she has written so many Tamil literature books. And she's a member of IMA Dindigal, and she's a founder secretary of the Dindigal OG Society, and she's been a president for the past 10 years. And she has done wonderful work for the Dindigal Society. Welcome, madam, for the program.
I think it's a matter of great pride that we have such senior stalwarts with us today in the program. Can we have the next slide, please? It's also my privilege to introduce Dr. G.B. Madhavi, the president of the Karimnagar OBGYN Society. She is a professor at the CAIMS Medical College and also a fetal medicine consultant at Sai Raja Diagnostics. Welcome, ma'am. Next slide, please.
I would like to welcome the Secretary of Tirunelveli OG Society, Dr. Pushpa Raju, a great academician. She's a consultant and director of Krishna Maternity Home and Pediatric Center, Tirunelveli. She's done an MBBS from Tirunelveli Medical College and post-graduation from Madurai Medical College. And as I was telling Pratik, they are a very reclusive society because they usually attend only the serious academic programs that we have seen in Tamil Nadu. And I think it's a privilege that we have her in our program today. Dr. Pushpa, welcome to the program.
Thank you so much, respected chairpersons. And our first speaker of the day is our Joint Secretary of AMOGS, Dr. Sujata Dalvi. And for her formal introduction, I would hand over to the chairpersons, requesting all the panelists and everybody who is not participating in these sessions to please keep your audio and video off. I myself will recede into the background. We hand over to the chairpersons.
Hello, good afternoon all. Pratik, Dr. Charmila and the entire here as chairperson for this particular webinar. It's a pleasure to introduce Dr. Sujata Davi. She's a consultant obstetrician and gynecologist from Mumbai, attached to so many hospitals. She's an honorary clinical associate at the Nauroji Wadia Maternity Hospital and Jagjeevan Ram Hospital. She's assistant editor of JOGI, the Journal of OBGYN of India, which is the part of Foxy. She's a member of Managing Council of Mumbai OBGYN Society for the last 15 years, and currently she's the first Joint Secretary of AMOGS. So it's my pleasure to present to you Dr. Sujata Davi.
I will need to unmute yourself, please.
Yeah. Thank you, Parag, for such kind introduction. At an outset, I would like to thank the organizers Dr. Pratik Tambe and Dr. Charmila, and also Bharat Serum and Science Integra for giving digital platform for today's webinar. And I'll be speaking on RH isoimmunization, management of negative pregnancy. So globally, if you see RH negative, it's not very common in Southeast Asian countries. It's more common in the Western world as such. But still, RH negativity, highest incidence is in the country of Spain, almost about 30 to 35%, whereas in the Western world is about 15 to 16%. But when we come to the Asian and Southeast Asian countries, it's just about 2% or even less. But still, we find quite a few patients with an RH alloimmunization. Nigerian study in one country said they found different prevalence in different parts of the country, 4.5 at Southeast Asian side, 0.7 in the north, and 5.5 in southwest if you go to see. If you go to see the pathophysiology, there are two commonest systems of blood group classification. One is an ABO system and second one is a rhesus system. ABO system, we divide the blood groups into A, B, AB, and O depending upon the antigen. Rhesus system is either rhesus positive or rhesus negative, but they do have E small d. D small d is not existent nowadays. They don't represent small d as such. E small e and G. D antigen is considered to be the most immunogenic so far as rhesus factor is concerned as compared to the other factors. If you see the pathophysiology, if wife is RH negative and the husband is RH positive, he could be either heterozygous or homozygous. If he is heterozygous, then there are 50% of chance that the children would be RH positive. If he is homozygous, then all children would be RH positive, and that is where some trouble lies. So what exactly is a feto-maternal hemorrhage and RH incompatibility? The amount of fetal blood which is necessary to produce RH incompatibility varies from person to person. It can be as little as 0.1 ml of RH positive cells, also can give rise to RH incompatibility or fetal dissing, or there are some studies who have said that almost about 30% of the patients with RH negative never develop RH incompatibility, even when they are challenged with large volumes of RH positive. So on one side, you see even 0.1 ml of RH positive can sensitize this RH negative, whereas even large amount of RH positive sometimes cannot sensitize this RH positive person. So RH alloimmunization occurs in by one of the two mechanisms. The first and foremost is after incompatible blood transfusion. That is by mistake. If you give RH positive to an RH negative, he or she is likely to have blood transfusion reaction. And second one is after feto-maternal hemorrhage, after mother and child, especially the fetus is RH positive and the RH negative. Now, feto-maternal hemorrhage may occur during pregnancy. That is almost about in 10% of the cases, and after delivery, it generally occurs in about 90% of the cases. Most of the fetal RBCs are detected in the maternal blood in all three trimesters. That is first trimester up to 7%, second trimester 16%, and third trimester almost up to 29% without disposing factors as such. An initial maternal response to RH sensitization is there will be low levels of immunoglobulin, which would be IgM because they have just been freshly produced, and this IgM will be there in the maternal circulation, but because it is IgM, it will not be able to cross the placenta as such. And later on, within 6 weeks to 6 months, this IgM becomes IgG antibodies, and then they are able to cross the placenta. And when they cross the placenta, they would destroy the fetal RH positive blood cells. So firstborn infant of an RH positive blood is generally not affected. It's only in the second and the third pregnancy that you find a child is affected, provided the mother is not immunized. So it's a short exposure of the first exposure from mother to fetus RBCs is insufficient for production of significant amount of IgG immunoglobulin response, and hence the first child is usually not affected. Then what happens are the sequence of events in utero. One is in maternal IgG. It enters into fetal circulation via the placenta. Then what does it do? It destroys the fetal red blood cells, giving rise to fetal anemia. the heme which is formed gets converted into bilirubin as such, and there is what is known as an fetal hyperbilirubinemia. Both are neurotoxic as such, and therefore these needs to be effectively cleared by the placenta, and this is generally done by the mother because of the placenta. And there are sometimes you get extramedullary erythropoiesis which also gets stimulated, and which results in what we call it as an hepatosplenomegaly as such, and there are immature erythrocytes which are also produced. When the cell destruction exceeds that of the production, severe anemia occurs, and when there is more demand on extramedullary sites to produce the mature red blood cells, you have hepatosplenomegaly, with both organs have to work quite a bit, and then you have a heart failure which eventually results, if it is not treated, with ascites, edema and pericardial effusion, what we call it as an erythroblastosis fetalis. And hydrops fetalis occurs when hematocrit value falls below 15%, which often results in fetal death if it is not treated on time, shortly before or after birth. Male to female fetuses, the ratio is 13:1. So 13 male fetuses are more prone as compared to the females. This is just a diagrammatic representation of the same thing, that Rh negative mother with Rh positive partner or the husband, and then you have first child which is not affected. The second child, when this Rh antibodies, when they cross over and goes onto the fetal side, crossing over the placenta, it brings about destruction and brings about the changes. It's the same thing which I've told you. So risk and severity of sensitization response increases with subsequent pregnancy involving even ABO compatible fetus with Rh positive blood. So without prophylaxis, remember this is very important, the risk is almost about 16% after 2 deliveries. So if the mother is not immunized, she will have, the babies will have chance of 16% of getting affected if it is not given prophylaxis, whereas it is 1 to 1.5 to 2% in an antepartum case, antepartum status, 7% within 6 months of delivery, and 7% manifest early in the second pregnancy as such. So with prophylaxis, that is when you give anti-D, risk almost drops to about 0.1%. So this is a drastic difference, that with prophylaxis of anti-D injection, the risk drops to almost about 0.1%, whereas if you don't give anti-D injection, then the risk rises to almost about 16% after 2 deliveries. The risk depends upon 3 main factors. One is in volume of transplacental hemorrhage, the extent of maternal immune response, and concurrent presence of ABO incompatibility. Also, that is, it acts as the risk drops to almost about 1.5 to 2% in case they have an ABO incompatibility also. But we'll deal with only with Rh incompatibility. So Rh incompatibility is of a medical concern only for those females who are pregnant or who plan to get pregnant in future. So it is very important for those females who are planning to become pregnant. You need to find out whether the patient has any positive history of being sensitized before the pregnancy. So in case she has had some abortion, which could be medical or surgical, medical abortions, one has to keep it in mind, because there are some patients who have taken this medical abortion pills, and sometimes even the blood group has not been tested. So very likely that she could already be sensitized before she plans to have a pregnancy as such. Invasive procedures like amniocentesis or chorion villus biopsy samples, abdominal or a pelvic trauma, antepartum hemorrhage like placenta previa or an abruptio placenta, intrauterine fetal death can also give rise to a potentially sensitizing agent, multiple pregnancy, manual removal of placenta, ectopic pregnancy, and a C-section delivery where there are more chances of fetal-maternal hemorrhage. Other aspects, the history needs to be explored, that is previous history of any blood transfusion, patient's Rh blood group type, that is, and in case you find that the patient is Rh negative, it is always better to find out the blood group of the spouse as such, whether he is Rh positive or he is Rh negative. And in case the spouse is Rh positive, you need to vigorously monitor the patient who is Rh negative as such, all previous pregnancies and outcome and the intervention. And in case there is history of hydrops in the previous pregnancy, then there are 90% of chance that the next pregnancy or the current pregnancy patient could have an hydrops fetalis. If there is a previous administration of IgG antibodies, if there is an injury in case of a maternal trauma during pregnancy, if there is a presence of vaginal bleeding which is there right from the first trimester onwards as such, or if there is a prior invasive procedure, one needs to keep it in mind that patient could already be sensitized. What's the objective of an antenatal management? One is prevention of an Rh alloimmunization, in Rh negative unsensitized women, that is women who are not sensitized as such, you need to prevent further Rh alloimmunization. So you need to take protective steps to prevent this from happening. Early detection and treatment of fetal anemia in already sensitized women, that is women who are already sensitized. When she is pregnant next time, you need to find out whether the fetus is affected or not, or in case the fetus is affected, you need to treat this fetus so that you have a better outcome. So sensitization, whether a patient is sensitized or no, it is detected in the pregnant women by what we call it as an indirect Coombs test, and that is why you can find out, or you can also find it out from Rh antibody titers, which they give you titers in a different dilutions, as starting from 1:4, 1:8, 1:16 as such. Anything more than 1:16, we call it as a sensitized. The more higher the dilution, and if you get positive result, it means that the prognosis is not very good. If lower the dilution and you get positive result, up to 1:16 is taken as that prognosis would be quite good. This is a flow chart for an Rh negative mother as such. And in case father is Rh positive, in case if you have to get an antibody titer, though here it is mentioned between at 20 weeks, 24 weeks and 28 weeks, it's always better to do whenever patient comes as a first antenatal visit and you know that she is negative and the husband is positive, it is better to get an Rh antibody titer done even as early as even in the first trimester as such. And if it is negative, then you need to administer at least prophylactic dose of immunoglobulin, that is anti-D, at around 28 weeks of gestation. And then at the time of delivery, you find out if the baby's blood group is negative, you need not give any further dosages. In case you find baby's blood group is positive, then you still need to administer another 300 micrograms of Rh antibody as such. In case you find that the first antenatal visit or later on you find that the mother is Rh positive, then how do you manage these patients? These patients are managed as an Rh sensitized pregnancy. And though it is here mentioned, it is amniocentesis, it is better to monitor these patients very actively. And you need to find out color Doppler and find out the mean cerebral artery velocity as such, and find out whether the baby has fetal anemia or not. And depending upon the MCA values, you need to treat these patients rather than doing amniocentesis and optical density at 450 nm as such. What are the precautions that you need to take whenever you're delivering a patient who is Rh negative with a baby who could be Rh positive? Would be to ensure consultation with the neonatologist as such, that you make sure that the neonatologist will be present at the time of delivery. Do not give oxytocin at the delivery of the anterior shoulder as such. Wait till the placenta comes out, and then maybe in case oxytocins are required, you can give oxytocins. If you don't need the those oxytocins are not required, you can just get away without giving any oxytocins as such. Manual removal of placenta, if at all, if it is required, you need to do it very gently so as to reduce the feto-maternal hemorrhage as such. Blood transfusion, if it is indicated, one has to make sure that you give only Rh negative blood transfusion to these Rh negative mothers as such. Early clamping of the umbilical cord is also indicated, and leave the cord little bit long as such. So in case something needs to be done or some procedure needs to be done, you have enough length of the cord as such. Postpartum management, in neonatologists, I've already said, send the cord blood for sampling for at least ABO and Rh typing for so far as the fetus is concerned. Direct Coombs test. Hemoglobin, find out the hemoglobin, bilirubin levels, and also the peripheral smear. If fetus is Rh negative, no further investigations are necessary. In case fetus is Rh positive, then you need to find out how much of an immunoglobulins are to be needed, and that is the reason they say you need to do a 4-step lab test, but it's not necessary that you always need to do it. Only if you suspect that the feto-maternal hemorrhage could be little more, then only it is do it. Otherwise, this 4-step laboratory test is not available everywhere. So it is not mandatory that you need to do it. But in case you have to do it, then you have what we call it as a rosette fetal RBC screen for a feto-maternal hemorrhage, which will tell you whether there is a feto-maternal hemorrhage which is present or not, or whether mother needs to be sensitized or not. Then we have Kleihauer Bettkes test, which will quantify how much amount of the feto-maternal hemorrhage is there. That way you can justify how much amount of an anti-D or immunoglobulins needs to be given to these mothers within 72 hours of the delivery. One can also find out the estimate volume of the feto-maternal hemorrhage by finding out the percentage of the fetal RBCs into the maternal blood, and thereby you calculate the dosage of anti-D which needs to be given within 72 hours of the delivery. So these are the lab tests, but it is not mandatory. I'm telling you that in case you find that everything has gone off smoothly, 300 micrograms of anti-RH anti-D within 72 hours of delivery is sufficient enough. This is just a diagrammatic representation of a rosette test where you find, in case you find immunoglobulins which are present, you have a picture something like this. Acid dilution test, this is to find out how much amount of the feto-maternal hemorrhage is taken place, and that way one can calculate the amount of an anti-D to be given. Now, for sensitized women, the management is guided by the following, that is presence or absence of any history or affected fetus in the previous pregnancy. Like in case previous pregnancy, the fetus has got severe anemia or high drops, then you need to do a maternal antibody titer at more frequent intervals, maybe every 4 weekly or 6 weekly or whatever it is. And sensitization is determined by doing antibody screening test, by doing indirect Coombs test. That is, apart from RH antibody titer, you can also do ICT and carry out. So this is a direct Coombs test which is done generally on the cord blood sample, and indirect Coombs test is done on the maternal sample as such. And then the management of a sensitized RH negative women is, in case there is no previous history of any fetus which is affected, then you find out the blood group of the husband. If it is negative, there is no need to do any other thing. But in case it is positive, I've already told you, you carry out an antibody titer in the first trimester, second trimester, and also in the third trimester as such. In case the antibody titers go beyond the critical level after 32 weeks, 34 weeks, you just have to deliver the patient. There is no need to continue the pregnancy beyond that. But in case the titers below the critical level, then you need to find out what we call it as a color Doppler study as such. And from the color Doppler study, you find out the possibility of fetal anemia as such. And in case you find that there is a possibility of fetal anemia, then fetus might need some intervention as such. But in case there is no possibility of fetal anemia, you can repeat the color Doppler after about 4 weeks or whatever it is. Continue pregnancy to maximum at least about 34 weeks, and then try and deliver the patient by around 34 weeks or so. In case the patient has a history where previous baby is affected, now these are the patients which need to be monitored more frequently as such. So these are the patients, after doing color Doppler on an MCA, you find out maybe you might have to do some sort of an intervention as such to find out what is the fetal hemoglobin as such. And in case if it is detected, then sometimes they do hemoglobin and IUI at the same time, because it's no point puncturing the fetus at one point just to find out what the hemoglobin is and then IUI. So generally the judgment is done only on the basis of an color Doppler study and to find out whether fetus has got anemia or no. And that is the reason after giving IUI, and then you decide when to deliver the patient. So these are the babies. In case they find that everything is okay, then they sometimes try and deliver them anywhere between 32 to 34 weeks. Ideal would be 34 weeks, but anywhere between even 32 to 34 weeks, babies have a better prognosis as such. Now, what are the amp? Then this is something which used to be done, but nowadays it is not that much done ever since the color Doppler, and we have what we call it as an MCA values of a color Doppler, and we can find out how to detect a fetal anemia. When the color Doppler was not there in good old days, at that time they used to do an amniocentesis and find out the level of bilirubin and find out ODD at 450 nm as such, and then find out what exactly is the fetal levels as such. And that is the reason you need to find out. But nowadays we don't do this as such, because we have what we call it as a color Doppler studies, which I have been repeatedly saying the same thing. The middle cerebral artery color Doppler study, it gives a very accurate and non-invasive screening tool for detecting moderate to severe fetal anemia. Sensitivity, mind you, is almost about 100%. There are only 12% false positive result for so far as fetal anemia is concerned. And the usage of color Doppler has resulted in almost about 80% reduction in an invasive test like an amniocentesis or a chordocentesis as such. Okay, so but you just have to rely on color Doppler, but it needs to be done by somebody who is quite experienced and who can accurately give you the result. Now, middle cerebral artery velocimetry is not useful before the 18 weeks of gestation as such, because reticular endothelial system is too immature to hemolyze enough cells to cause significant anemia. So it's no point doing it. You need to do it from almost about 18 to 20 weeks, or maybe from 24 weeks onwards till about say 32 weeks onwards as such. It is not a reliable predictor for severe anemia after 35 weeks. So only up to 34 weeks it has that much of a sensitivity, and it is found to be similar or much better than amniotic fluid OD at 450 in prediction of anemia. So it is very important that middle cerebral artery color Doppler is very important so far as detection of fetal anemia is concerned. This is a picture of a normal middle cerebral artery Doppler, and this is a picture of a rhesus isoimmunized. You see how much of it has gone up. So the peak value is quite high, and that's how it indicates that, okay, this child or this fetus could be having a fetal anemia. Now, results of middle cerebral artery velocimetry as such, if you go to see if it is an unaffected or mildly affected fetus, and if you have a normal color Doppler, then it is color Doppler needs to be required monthly. Even if you don't do it monthly, once in 6 weeks is good enough as such, and deliver these babies at term, generally at around 36 weeks or after checking for the lung maturity as such, because these fetuses are at low risk so far as intrauterine fetal death is concerned. If it's a moderately affected fetus, and if MCAD is almost about 1.5 multiples of medium as such, then you repeat color Doppler every 2 weekly as such, and deliver after lung maturity or enhancement of a lung maturity may be necessary. Generally, they try and deliver these babies anywhere between 32 to 34 weeks as not wait even up to 34 weeks as such. And in severely affected fetuses, when MCAD is more than 1.55 MOM, or if there is a frank evidence of fetal hydrops, then these are the fetuses which you need to help them by attaining lung maturity, because there is a high risk of an intrauterine fetal death, and these fetuses, they have to undergo some sort of a treatment, what we call it as an intrauterine infusion, and then they take a call after checking the fetal hemoglobin level when to deliver these patients. In the meantime, you give steroids to the mother as such, so that you can deliver the fetus if and when required at any time. Now, this is a Lillet's chart which we used to follow when we were the residents, and when we used to do amniocentesis and find out the bilirubin and ODD at 450 nm, and it used to be zone 1, 2, and 3. Zone 1 means you just keep the patient under observation. Zone 2 is you just monitor the patient and may try and deliver before 36 weeks. And zone 3 means immediately you try and deliver whenever you have done an amniocentesis, because this baby is not going to survive and baby might not have a very good prognosis if you continue with the pregnancy. This is a Queenan's chart as such. This chart is supposed to be a little better than the Lillet's chart, but both are used for the same. But nowadays we don't use it, because ever since we have a color Doppler which is available, we can diagnose fetal anemia even without doing any interventional test as such. Now, if you go to see RH sensitized, again the same thing. If it's an MCF Doppler velocimetry, if it is PSV is 1.5 MOM or above, then you need to find out fetal blood sampling, and then you can consider the baby for an IUI. If these facilities are not available, then what you need to do is you do an amniocentesis, find out the bilirubin levels and find out OD at 450 nm and put it onto the chart, and that way you decide what further treatment to be given or no. In case MCA PSV is less than 1.5 mm, then you just have to monitor these patients and repeatedly keep on doing color Doppler every 4 weekly or maybe about every 2 weekly if the need arises, and that's how you monitor the patient. In the meantime, give steroids to the mother, so that anytime if you have to deliver the baby, at least baby does not have any pulmonary lung maturity issue as such. Now, coming to intrauterine transfusion as such, if it is recommended only in those fetuses who have severe anemia in utero, it is typically carried out not between 18 weeks, I would put it between 20 weeks to almost about 32 weeks, not even up to 34 weeks as such. It may be given intraperitoneal or intravascular. The commonest is intravascular, that is you just puncture the umbilical vein from the point when the cord is just taking its coming out from the placenta. That's the easiest way that you can get an umbilical vein entry as such, provided the placenta is anterior. If the placenta is posterior, it is difficult. Then you find out from the umbilical cord entry into the fetus, and that's where you can get the umbilical vein properly. There's only one umbilical vein and two umbilical arteries. It may be intraperitoneal. Not many people are doing it nowadays. Most of the people nowadays, we are doing intravascular. You take you take ORHD negative packed cells with a hematocrit of almost about 80% is used, and the amount to be transfused is calculated depending upon the gestational age minus 20 multiplied by 2 if the gestational age is more than 20 weeks of gestation as such. This is how you can do it. This is the insertion of cord over the placenta. This is the easiest way to get an umbilical vein. But in case placenta is posterior, as what I said, it's difficult to negotiate there. And then that is the time you might have to just find out a point where the cord enters into the fetus as such. And that's where one could get an umbilical vein as such. The sensitized Rh negative women, in case if it's a postpartum management so far as neonate is concerned, if baby, if it is alive, should be admitted in NICU as such, because baby is kept under observation for few days till baby settles down, and then only taken out of the NICU. Urgent exchange blood transfusion in case it is needed, depending upon the baby's hemoglobin level and the bilirubin level. So that way they decide to do it. And in case if it's a mild rise in the bilirubin level, then maybe phototherapy is given if it's a mild rise in the levels of the bilirubin. Now, special feto-maternal risk states as such, that in case patient has had an abortion, which could be in the first trimester, there are up to 50% of chance that the mother could be sensitized, and hence we recommend the dose of 50 micrograms, which is recommended in the first trimester. The abortion may be either surgical or medical, irrespective of whatever it is, you need to give sensitizing dose as such. If it's an invasive fetal procedure, then it is almost about 11% of sensitization occurs, and that is the reason the dose which is recommended is about 300 micrograms, which is recommended. In case there is an antepartum hemorrhage, like an accidental hemorrhage or a placenta previa, then again you need to give 300 micrograms stat, and it needs to be repeated 12 weeks later in case pregnancy lasts more than the 12 weeks of giving the first dosage as such. And carried out some procedure like an external cephalic version, which we nowadays don't do it, but occasionally in case somebody has done it, then there are chance almost about 6% of sensitization. These are the patients who needs to be given 300 micrograms, and that is the main reason why we give prophylactic dose of 300 micrograms at 28 weeks of gestation as such. Now, delivery with feto-maternal hemorrhage, normal amount of fetal blood which enters into maternal circulation is almost about less than 0.5 ml. So, even this minuscule amount only of fetal blood enters into maternal circulation, and dose of anti-Rh anti-D, that is 300 micrograms, will neutralize almost about 30 ml of the whole blood, fetal blood, or 15 ml of Rh positive cells. So if you go to see, the dosage of 300 micrograms is able to neutralize almost about 30 ml of whole fetal blood. So management is guided by the estimated volume of feto-maternal hemorrhage, which is done by the lab test, provided you feel that the fetal-maternal hemorrhage is much more, and whatever amount of dosage that you have given to the mother may not be sufficient, then these are the patients where you need to find out quantitative analysis of how much is the feto-maternal hemorrhage. The recent advances so far as Rh isoimmunization is concerned is non-invasive fetal Rht genotype, that is from, you have what we call it as a cell-free DNA, which is there in the maternal circulation, just as we do NIPT, similar to that way that you take out mother's blood and find out how much of the fetal free cell DNA which are there in the maternal circulation, and that way you can find out what would be the blood group of the fetus as such. Point of care test, that is the rapid test, the lab test, which I've already told you. In case you feel that the feto-maternal hemorrhage is more than expected, then you need to carry out this lab test as such. Lower than 50 micrograms of dose preparation for an Rh IgG for usage in the first trimester abortion. I don't know how much of this will be useful, because what we get it is, we don't even get 50 micrograms. What we get it as 100 micrograms of an Rh isoimmunized. So that is the reason I don't know, lower than 50 micrograms, how much of it would be useful as such. And concept of partial D and weak D antigens, that is what we call it as a heterozygous and a homozygous. They say heterozygous means it's not a heterozygous as such, but only the antigen which is there, the antigen, it's little weak as such. So the take home point is, Every woman of a childbearing age should have her ABO and RH type done at the first antenatal visit as such. Whenever she comes, the blood group has to be done as such. Then you obtain an ABO or RH type of the husband of the women who are found to be RH negative. Very important is that the moment you find that the women is RH negative, you always find out the spouse's blood group as such and find out whether they are RH positive or no. Ensure that the ICT is done at 20, 24, 28 weeks of gestation for appropriate prophylaxis. I would put it as ICT to be done at first antenatal visit, then in the second antenatal visit, second trimester, that is at 20 weeks, and in the third trimester at around 24, 28 weeks of gestation. And single postpartum dose may be inadequate in cases of severe fetal-maternal hemorrhage, and that is the reason what we give is an antenatal prophylaxis as such at 28 weeks and then postpartum. So that covers up whatever amount of the fetal-maternal hemorrhage that might take place. Even if it is more than the usual, generally it covers up for the same. High cost of immunoglobulin, that is up to the pharma people and the manufacturers to decide how to bring down the cost as such. Lack of resources to adequately investigate and monitor the features in utero. Yes, it is. This is very important because not all centers provide the facilities for color Doppler. Not everybody is trained trained to do the color Doppler studies. But in case you have a color Doppler studies which is available in most of the centers, then there would be less chances of any invasive procedures like amniocentesis as such, and we will be able to detect these features as much better on time as such, so that you can give proper treatment as such. Low turnout for antenatal clinics or the missed cases. This is only for those places where the antenatal turnout is not that much, or there is not that much of an awareness that they need to visit the doctors at a regular intervals, and these are the cases where there are chances that there could be a missed cases as such. Poor documentation of prior sensitizing events. Some are yet to fully grasp the importance of the same. That is, sometimes they don't sometimes they don't give you the proper history of previous abortion, especially if they have taken medical abortion pills as such, then they don't come and tell you. Even the history of blood transfusion, at times they don't come and tell you. So these are the things which you have to dig it out from the patient in case you find that the patient report shows that she is sensitized as such, and loss of case notes as such. But that is for us as a medicos to decide, that you preserve all the data with us so that you don't lose out on any of these patients as such. The recommendations is advocacy of partnership with government and NGOs to subsidize the cost of immunoglobulin. That is very important. We still need to subsidize the cost of immunoglobulin. Special insurance cover of RH negative to ensure the case of procurement when needed. This I find it little doubtful, because even pregnancy per se does not come under the insurance cover as such. Only very selected multinational companies, they have their pregnant employees who are pregnant, they come under the insurance. Otherwise, most of the insurance, they don't cover up the pregnancy. So this looks little bit doubtful as such. Involvement of clergy as a part of a premarital counseling. I wouldn't put it as clergy, but premarital counseling should be brought forward as such, and there should be awareness that they need to undergo premarital counseling. Then automatically the blood group of both the one to be married, that is husband and wife, would be known to us. And creation of special fora or groups for an RH negative, a potential of RH negative. This looks little difficult, and I would try to advocate the same as such. Okay. And then rhesus alloimmunization, the real problem and the real effort needs to be made to mitigate its impact as such. This is by bringing about the awareness that blood group of both the wife and the pregnant patient has to be done, and if she is negative, then the husband's blood group has to be done. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of newborn still remains. You don't find so much in the metropolitan cities, but in rural areas, or we do get some patients who are transferred from the rural areas, and we do find some of these cases where we find this hemolytic disease of the newborn is there. Great advancement have been made in detection of management of this condition, but many of our RH negative mother can now have a happy obstetric career. Definitely most of our or all of our RH negative mothers will always have happy obstetric career, provided we bring about the awareness among the women that they need to get themselves checked so far as their blood group is concerned. Thank you so much. And I would like to thank the organizers for giving me this opportunity.
Charmila ma'am, would you like to welcome Dr. Amaladevi and Dr. Madhavi.
May I request Dr. Amaladevi madam and Dr. Madhavi madam to say a few words about the talk. Dr. Amala madam. No, we can hear you, madam. Amala madam,
This is first of all, I thank the organizers, especially Dr. Charmila, for giving me an opportunity to chat the session of RH isoimmunization. Actually, this is a wonderful and very elaborate, very clear-cut talk. It was like a cascade actually to tell about. Then antenatal, postnatal, prophylactic, everything was very clearly narrated. Though prior to prophylaxis treatment, it was one of the significant cause of perinatal mortality and morbidity. So there is a decline in the incidence after the introduction of anti-immunoglobulin. There is education and commitment at the moderate cost, as Dr. Sujata has she had registered. The common people, the village people are not able to get the medicine because of the high cost. If they are delivering in government hospitals, okay. If they are in private hospitals, sometimes they find it very difficult. So, as she had told, the company should come forward to give it in a moderate price. And one more incident I want to tell this in this forum is that some few years ago, when I was in government setup, one of the staff nurse, they used to get the drug from outside only. It was not available in the government hospital. So they used to get from the OPA, and she had given it to the child instead of giving to the mother. So when I had a doubt, I asked her for whom you had given. She said, I had given the injection. I had given the injection, but I went away, and then I had a doubt. And I came back and asked her. She told me that she had given the injection to the child. So this much of information, so clear that all the paramedical staff who are administering the injection should be educated. The parents should be educated. The doctors as well as the paramedical staff also should be educated regarding to whom to give the anti-immunoglobulin. Then I made her to get again one ampule from her own pocket, and then I asked her to give to the mother. So this was one of the things which happened. This happened in 90s, late 90s. So this was a very nice talk, and I'm very privileged to thank again the conveners for this giving me an opportunity to attend the meeting. Thank you.
Thank you, ma'am. It is a pleasure to see you after such a long time. We have not met since lockdown, and your experience talks, and it was a very good advice which you had given to the juniors. Check whether the paramedical has given the correct injection.
Dr. Sujata Devi wants to respond, I think.
Charmila, yes. I just want to say, our time it was a rule that any anti-D has to be given by the doctors, only the resident, not even a paramedical, because this would happen sometimes, and sometimes you don't know whether the injection has gone in properly or no, and patients spend so much of money. And second thing, we were always told to give it on deltoid and not on the gluteus muscle, you know. So these are the two strict instructions that we were given, that only it has to be given by the doctor or the resident, and it has to be given on the deltoid muscle as such, you know.
Thank you so much, ma'am.
Any comments from Dr. Madhavi or Dr. Pushpa Raju, ma'am?
At the outset, let me wish everybody a very good afternoon. It was a very good talk, very extensive, giving all the details. Madam, it was a very good, informative talk. And one important thing from the periphery, especially, where I wanted to tell everybody is that during our routine antenatal visits, we are not really informing the woman that she has to get immunization antenatally and postnatally. Because she comes for all the visits, we do give the antenatal, but postnatally she gets delivered somewhere in a PHC or in a remote place, and she doesn't know that she really has to be immunized after checking the blood group of the baby. So if we put into our practice to make sure that the mother understands that it has to be taken postnatally also in our protocols, then I think the immunization, so much of effort that we are taking to prevent this immunization would be in a better way. That's what we are trying to put in our practice, educating the women
Yes,
in
ma'am.
the antenatal period. Thank you. Thank you.
Thank you so much, ma'am. Pratik?
Good afternoon, everybody. I'm Dr.
Good
Pushpa.
afternoon, ma'am.
Good afternoon,
And
Pratik.
I wanted to add one more point to this. And so many of the patients going in for medical abortion and forget to get the dose of anti-D immunoglobulin. So that we have to stress the patients to get that. And after ectopic pregnancy also they forget to give the anti-D immunoglobulin. So that also we have to teach the patients to get the anti-D dose also. Many of the patients going in for medical abortion especially, they forget to give the dose of anti-D immunoglobulin. That we have to teach the patients.
Thank you, ma'am. Backend team, can we have the CV slides up, please? I would request Dr. Arun Madhav Barua, our chairperson, to introduce the next speaker, Dr. Charmila. Sir, you will need to unmute yourself.
Charmila is the main person behind the whole program, so she's already been known to everyone, but the custom already done. She needs to be introduced formally. And it's a great pleasure for me to introduce Charmila, with a very close friend of mine and highly knowledgeable lady that she is. She has been a chairperson of the Clinical Research Committee of the Federation from 2016 to 2018, president of the Menstrual Hygiene Management Consortium, joint treasurer of the Indian Fertility Society Tamil Nadu chapter, director of Aditi Hospital and Parvati Ayuba Fertility Center at Trichy, is the consultant to Southern Railway Hospital Trichy, awarded Sri Mohanlal Desai Prize for standing first in a DFE, past secretary of the Trichy ONG Society, organizing secretary of the Yuva Foxy South Zone in 2013, has won 5 trophies of Foxy as secretary of the Trichy ONG Society. That's a huge applaud to her. HMS champion, Foxy 201, recipient of Mrs. and a Pandit Prize for the Women Empowerment Foxy 2015. And lastly, she has been awarded a prestigious Dr. Mehru Hanchotia Prize for the Committee of Foxy in 2018. She is a very hardworking lady. I know her inside out, and I'm more than sure that she is going to give us a very brilliant talk. There is no doubt about that. And the virtual floor, Charmila, is yours. I'm sure I have not left anything, but I know go on and on about you. And this is the platform that I will be giving to you. Charmila.
Thank you so much, sir, for those sweet words. Thank you so much. It's my pleasure to give a talk in a program where Dr. Pratik is a convener, because his meticulous detailing is one which everybody needs to emulate. And that too in a webinar, he does it so clearly and with so much clarity. Thank you, Pratik, for that. Can I screen share?
Yes, please go ahead. There are over 500 viewers tuned in, waiting to listen to you with bated breath.
So when we were undergraduates, we were like patients will walk in, deliver, and we hardly monitored any labors. And suppose one of our PGs or assistants call us, then we go and we do what they ask. That's what was an undergraduate work. And then when we became postgraduates, we hardly had time anyway to check whether a labor was functional or dysfunctional in many cases. The nurse will call us and then we'll go and deliver. But as we pass out and come as private practitioners, and you see a patient from start to till end, and when the relatives are on your back asking you when she'll deliver, how she'll deliver, and whether she'll deliver a male baby, that's what in Tamil Nadu it happens always. And that is what made me interested to know what dysfunctional labor is. So the first thing, it started with Friedman in 1954. He was the one who conceptualized labor, and he graphically represented labor, and he plotted cervical dilatation and descent to the presenting part against time, divided the labor into 3 phases as latent phase, active phase, and deceleration phase. That is all the first stage of labor. And this is the Friedman curve. We know there is an acceleration phase after the latent phase. There's a maximum phase, a slope where the maximum dilatation happens, and then there's a short deceleration phase, and then the baby starts delivering by descent, and that's a second stage. It's actually a hyperbolic curve, And there's little initial change, but that is followed by rapid progression at the beginning of the deceleration phase, and that's what helps in the delivery of the baby. But in 1983, with Cohen, he formulated clearly the classification of the labor disorders. Dysfunctional labor came into the picture, and the latent phase, which prolonged, he called it as prolonged latent phase. And in the active phase, there are two phases, which are actually the protraction disorders as well as the arrest disorders. And next was the descent disorders. And what he called as prolonged latent phase was normally it should be at least 8.5 hours in a nullipara, but if it's more than 20 hours, it is called as prolonged latent phase by Friedman. And if it is 5.3 hours in a multi for latent phase, it can go up to 14 hours if it's supposed to be prolonged. The treatment which he advocated was bed rest. And he said the onset of labor pain, that is when the patient perceives the pain, up to the time it is 3 to 4 centimeters dilatation, it is called as a latent phase. So it gets delayed, but if it's called delayed, it should be at least 20 hours in a nullipara. And if it's going to be delayed in a multipara, it should be at least 14 hours. So what did he call as the arrest of dilatation? That is, a patient has gone into active phase at 3 to 4 centimeters dilatation. She's having regular uterine contractions, but she's not having any progress of labor for the next few hours. Then it's called as secondary arrest, but you need to differentiate it from a prolonged latent phase. Suppose there's no dilatation of 3 to 4 centimeters, she's just around 1 or 2 centimeters, and the labor is going on for a long time. You cannot call it as arrest, it is actually a prolonged latent phase. You need to have cervical changes to say that it's an arrested labor. Suppose the cervix is 100% effaced, but it's not dilated, it is called as early secondary arrest of dilatation. And regarding the protraction disorders, it is in the active phase. It is protracted if it's only 1.2 centimeters cervical dilatation in an hour in a nullipara, and it should be at least 1.5 in a multipara. Then only it's called as a protracted active phase. But you should remember that you could have actually wrongly diagnosed an active labor. It could be still false labor. But if there's definitely a confirmed that it's a protracted active phase, if it is going to be a cephalopelvic disproportion, you need to go for a cesarean now. If not, you can go for an expectant management with supportive treatment to the mother. And regarding the prolonged deceleration phase, it should be only 54 minutes in an early. And in a multipara, it can be only 14 minutes according to Friedman. But if it's more than 3 hours in an nullipara, or if it's more than 1 hour in a multipara, it can be called as a prolonged deceleration phase. The causes may be fetal malposition or shoulder dystocia. Please remember, when the cervix is fully dilated, it's around 8 to 9 centimeters, and after that there's no dilatation at all. Please remember, you can be shoulder dystocia loss because you have lots of diabetic mothers now delivering. If there's a prolonged deceleration with a higher station, it can be a cephalopelvic disproportion even after the cervix is dilated. And regarding the arrest disorders, as I said, there should be no cervical dilatation for almost two or more hours. Then it's called as a secondary arrest of dilatation. And the commonest cause, according to Friedman and Cohen, is inadequate uterine contractions, or it can be incoordinate uterine contractions, where the contractions are good, but the cervix is not dilating. And regarding the descent disorders, here also something called a protracted descent or a arrest of descent. If it's protracted descent, it will be like less than 1 centimeter per hour in a nullipara, and it can be less than 2 centimeter per hour in a multipara. And when there's failure of descent, it's just called no descent at all. And when you have to diagnose arrest of descent, even for 1 hour of full dilatation, there's hardly any change in the fetal descent, then it's called as arrest of descent. So the cause of protracted descent is, first is macrosomia, cephalopelvic disproportion. That is, the cervix is dilated, but it's not going beyond the deceleration phase. The next thing is hypotonic labor can still happen. Suppose the mother is excessively sedated, she can have something like a protracted descent disorder. Or if she's been given epidural, it can contribute to a protracted descent, or still a fetal malposition can contribute. So the treatment of all disorders is same. You have to first evaluate the feto-pelvic relationship. If it is normal, then you have to go for a diagnosis of poor uterine activity. And if it's available, you have to insert an intrauterine pressure catheter and a fetal scalp electrode. And suppose you're diagnosing inadequate contractions, you can use oxytocin according to Friedman. But the disorder, whatever you're treating, protraction, descent, arrest, whatever, it has to respond to oxytocin in the next 3 hours. And then one person came called as O'Driscoll, that is the Irish protocol. And this was the one we were religiously following as postgraduates and as practitioners. But now we know that it's not such a great thing, but we're doing it so aggressively, where is a standardized labor management protocol, and which O'Driscoll claimed produces a very reduced rate of cesarean section of only 5%. Here, the labor will be diagnosed with complete cervical effacement, show or ruptured membranes. You need not have a dilatation to say whether she has gone into the active phase, and she will be committed to deliver in the next 12 hours. And what he did was, you have to do frequent PVs every hour, and then for the first 3 hours when you do a PV and the dilatation is less than 1 centimeter per hour, he says you have to go for an amniotomy, artificial rupture of membranes. And you can wait for 3 hours then after an ARM, and you have to do a 2-hourly checkup now. And still, if there's no progress, you will need to give oxytocin in very high doses compared to the doses which were given before or now. But the studies have proved that there's no change in the cesarean delivery rate at all. Whatever he claimed that it's reducing cesarean section rates, it's not happening when it was followed by the other groups who are following the active management of labor. Then WHO came with its partogram, where it says latent phase can be only for 8 hours. Active phase starts at 3 centimeter dilatation, and they said it should be at least 1 centimeter per hour. And then they put up an alert line where the active phase is not 1 centimeter per cervical dilatation, even after 4 centimeters. That is, even after the active phase is started, and in the dilatation is not at least 1 centimeter per hour, you have to go into the alert mode. And then you can wait for 4 hours in WHO. And suppose it's still lagging behind, you need to go for an action. So in the slow action phase, you can actually wait for 4 hours in the WHO partogram. So next the question came was following the Friedman curve or following the O'Driscoll management of active management of labor contributed to the increasing cesarean rates, because the labor phases were not accurately described by Friedman. So there was a workshop at the National Institute of Child Health and Human Development and the American College in 2012, and they depended on 2-3 reports to tell them that there needs to be a change in the labor phases. And the first report was by the NICHD sponsored Safe Labor Consortium report by Zhang and his associates. So why they wanted to know was because in this you can see that in labor, the first stage arrest contributed to almost 15 to 30% of dysfunctional labor, and the next reason was second stage arrest. So dysfunctional labor contributed to the maximum number of cesarean sections in the evaluation by the American College. So there was a person called Zhang who has done extensive work on dysfunctional labor, and he evaluated 1,329 nullipara women who had a term baby, singleton, vertex presentation with a normal birth weight, and they waited for a spontaneous onset. They did not do any induction, but they excluded all the cesarean deliveries, and then they put it in a computer, and they computed the expected time interval of cervix to reach the next centimeter, and they found out the expected rate of cervical dilatation at each phase of labor, and the duration of labor for fetal descent at various stations. All these three were computed, and this was the curve they got. That is, you can find out like everything started only at 6 centimeters of dilatation. Whatever we were thinking as active phase as 4 centimeters dilatation, there was hardly any change at that point of time. The labor progress started increasing only at 6 centimeters of dilatation according to his assessment. So the results of this was, he found out that the cervix dilated substantially slower in the active phase. That is, it took almost 5.5 hours to go from 4 centimeters to 10 centimeters according to Zhang, whereas Friedman said it takes 2.5 hours. That is, the acceleration phase for him was 2.5 hours, but in this, it took almost 5.4 hours. And then there was no deceleration phase in the Zhang curve. Amala madam, I think you need to mute yourself. Amala madam, please mute yourself. Amala madam. Please mute, madam. Mute, madam. So in the second stage, the fetal descent can take almost 3 hours according to Zhang. And the reason which he quoted was, women now are older, they are heavier, and there is a more slow labor in spite of oxytocin augmentation. That is what the conclusion he came to. But Andy said there's a limitation in the Friedman curve because it is not a representative sample of the population. It's more of a graphical picturization rather than a statistical elaboration of the for labor. And they did not take into account special characteristics of labor data. And they adopted without a complete context the subject characteristics as well as the interventions which were followed. So according to the Zhang curve, it is not a sigmoid curve, it's an exponential rise. That is, there's a cut and it moves, a cut and a moves. It does not go like a continuous flow. You can wait for 2 to 3 hours for each centimeter of dilatation till 6 centimeters. And after that, the labor progress should be very fast. That's what the Zhang curve tells us, that it's an exponential rise rather than a continuous rise. So according to Zhang's curve, the key concepts which he gave are the transition of active labor happens only after 6 centimeters dilatation and should not be taken as 4 centimeters as we are taking depending on the Friedman curve. And he said there's no deceleration phase and the traverse times it's much longer latent phase and a much shorter active phase. So if you can wait till 6 centimeters and then label her as active phase of dilatation, that is the time you have a longer period of time to wait before you go for an intervention like amniotomy or oxytocin. Amla madam, please mute yourself, madam. Madam, mute pannirunga. Then there was the next study. There was a next study which was formulated in 2010, and this depended on the consortium on safe labor, and they gave a revised dystocia diagnosis after this study. Here they took 62,415 parturients, and they constructed a labor curve by parity. They estimated the duration of labor stratified by cervical dilatation at admission and then made it centimeter by centimeter. Every centimeter they computed in this graph. And the results also came. It takes 6 hours to progress from 4 to 5 centimeters. From 5 to 6, it will take almost 3 hours. So you can wait for 9 hours from 4 centimeters to 6 centimeters before you label her as active phase. After 6 centimeters, everything becomes faster. Up to 6, both the nulli and the multipara can have similar curves. After 6, the multipara will dilate very fast, and it can be a little slower for a nullipara. And in a multipara, after 6 centimeters, most of the time they deliver within the next 2 hours. So you have to remember, according to the Zhang curve, the active phase starts only at 6 centimeters and it's not 4 centimeters, as Friedman said. And this study also said the increasing maternal age, the maternal and fetal body sizes have made obstetrics a challenge now. And the frequent obstetric interventions which we do, like induction, epidurals, and oxytocin, has altered the natural labor curves which were found in 1954 with Friedman. And then the third study was by Spong in 2012, and he also came with the conclusion that you have to define adequate labor as more than 6 centimeters dilatation after the membranes have ruptured, and you have to call it as abnormal labor only if there's no cervical changes after 4 hours of adequate contraction after 6 centimeters dilatation, and after 6 hours of inadequate contraction after 6 centimeters. Before that, you cannot label it as dysfunctional labor. And second stage disorder, you can wait almost 4 hours if she's having an epidural, and you can wait for 3 hours without an epidural in a nullipara. So the 3 changes which came from the 1960s is prolonged labor can cause maternal neonatal morbidity. There was more of usage of oxytocin for uterine dysfunction, and they started preferring cesarean section compared to a difficult mid-forceps delivery. And then the American College came with its consensus in 2014 saying to reduce the cesarean rates, we have to change the definition of labor, and they actually accepted the recommendations of the SAFE consortium, and they said 6 centimeters is now considered the beginning of active labor, and you can wait for 3 hours for the second stage in a primipara and 2 hours for a multipara. And if they are giving an epidural, you can give 1 hour more to the nullipara and the multipara before you diagnose dysfunctional labor. But we have to realize, like, just changing the definition of normal dilatation help will prevent a preventable cesarean. That is, we want to prevent a primary cesarean rate, but will just changing the definitions help us to do this? So that's why I took into consideration these 2 studies of Friedman, one in 1954 for the primigravida and one in 1956 for a multigravida. And if you see the study, it is actually formulated after checking only the data of 500 primies. They didn't take a big study, it was only 500 primies. And in this study, please see, there was only a 38% spontaneous delivery. And there was 55% of outlet forceps delivery, 0.9% were mid forceps, 2.8% was breech deliveries, 0.9% were twin births. There was a 1.8 cesarean delivery. There was a 0.9% stillbirth and neonatal death rate. So please remember, Friedman curve was formulated only after analyzing the data of 500 women alone, and it stood the stood its validation for almost 60 years now before it has been challenged. So the characteristics in the Friedman curve, the women were almost 70% were between the ages of 20 to 30. Most babies fell into the normal weight range of 2.3 kg to 3.6 kg. Pitocin was used to induce or augment labor in only 13.8% of patients, and most of the women were sedated during labor. It was called as a twilight sleep, and almost 96% of the women were sedated with drugs. This was the characteristic of the women who went into labor during Friedman's time, where he formulated his curves. In this results, he has said latent phase was average was 8.6, active phase was 3 centimeters per hour, and the time between 4 and 10 centimeters dilatation is 5 hours, and second stage was only for 1 hour. These are the characteristics in 1950s. So the changes which has happened has been illustrated by Lohan in 2012, and he said nowadays we are using more of epidurals instead of sedation. Oxytocin is used much more frequently for both labor induction and augmentation. Women today are older and tend to weigh more, and the method of treatment of giving a forceps delivery for every woman after giving an episiotomy is no longer a routine practice now, and all of these factors can impact the length of labor which is happening now. So the comparison between the two types was done by Ragusa et al. In 2016. We compared the Friedman method of treatment with the Zhang method of treatment. Here, 419 Italian women were enrolled. Half had treatment based on the Friedman's curve, and the other half had the care based on the American College guidelines of 2014. In the Friedman's curve, what they said was the food was banned, as was done in 1950. The laboring women were restricted to bed, and they were asked to push on their backs. But in the new care model, the Friedman's curve was used as a screening tool to have the primigravida, the vertex presentation with a spontaneous labor. Here, there was more patients with labor, and the further assessments done, that is either a surgical or a medical intervention in the form of ARM or oxytocin, was done only after lots of thinking. They didn't do it without a discussion with the senior people. All the women were encouraged to walk during labor. They were asked to push and give birth in the position they found most comfortable. They were given free access to food and drink, and a standardized protocol was used to diagnose fetal distress in this group of women. And the results was the cesarean section rate was definitely more in the Friedman's model. It is almost like 22% compared to 10.3% in the newer group. And the newer model of care had fewer interventions, few had oxytocin or ARM. And regarding the newborns, the low Apgar scores, the low umbilical cord pH was higher in the Friedman group, but the average length of labor was the same in both the groups. That was the conclusion of. So it doesn't matter about the diagnosis of labor, the interventions which you're doing more or the supportive care which you give to a woman seems to matter much more than changing your graphs or changing your diagnosis of active phase of labor. Supportive care is much more important. So then after American College came with their guidelines, there was a rebuttal by Dr. Cohen as well as Dr. Friedman, who was in his 90s now, and that paper came out in 2017. And there are two studies on this. They have said the perils of the new labor management guidelines, and that was in 2015, and the viewpoint on the misguided guidelines for managing labor, which came in the American Journal in 2015. And what they said was the American College has ignored a half a century of corroborated research and the testament to the triumph of theory over experience. Even though it was only 500 women which they had taken into account, it has been validated for almost 60 years of experience. And why do the curves differ according to Cohen and Friedman was the nature of progress of labor has not changed in women, but how the data they've analyzed has changed. There are selection biases and uncontrolled confounders which can cause doubt on the validity of their findings. So the bias which they found out in the Zhang study was, Zhang study did not include cesareans. So it did not include the cases of dysfunctional labor who had gone for emergency cesarean section. And it also excluded the women who had come in very rapid labors. So they took only the slow labors, and that's why there's an overall appearance of slow average dilatation. And they've excluded the compromised newborns. So we don't know, like, if you're waiting for such a long time, is there going to be a morbidity in the newborn, or there's going to be a problem with the development of the baby. These major exclusions made the acceptance of the new guidelines difficult. And please remember, even in the Safe Labor Consortium, the cesarean rate was 30.5% in spite of changing the active phase from 4 centimeters to 6 centimeters. So there's no appreciable fall which the American College wanted in the cesarean section rates just by changing it from 4 to 6 centimeters. And if we are going back to the old method of waiting for the mother herself to deliver, and she being in a long time in a painful labor, what iron donor said, that dawn should not rise twice upon the same labor, cannot be followed at all. It's going to be like you're going to wait and you're going to have more problems with the mother. And what Williams Obstetrics, our Bible in obstetrics, tells us is, even though they are an American book, they have said when the second stage is increased beyond 3 hours with an epidural, as said by the American College, there are adverse infant outcomes when you increase it even by 1 hour. And the diagnosis of dystocia is still elusive. New definitions may not have a great impact on cesareans for abnormal labor. Please remember, safety is the much needed you need to follow in second stage of labor guidelines, because you cannot wait for more than 3 hours in a primary asking her to push when she's going to be in so much difficulty after a long first stage of labor. So for us Indians, we always find it easier to follow the RCOG guidelines because somehow we feel it's very near to us. Probably the British, this thing is still lingering on us. And what the RCOG says is, please do not follow the O'Driscoll method of active management of labor. That is that one-to-one continuous support. Definition of established labor is done very strictly. Early routine amniotomy, routine 2-hourly PVs, and oxytocin, the labor becomes low. This should not be followed. The active management which O'Driscoll had formulated in the 1990s. And if there's going to be a delay in the first stage, according to the RCOG, you have to wait for 4 centimeter dilatation to say that she's in the active phase. Delay is actually a cervical dilatation of less than 2 centimeters in 4 hours. That is, at least there can be a dilatation of only 0.5 centimeters. Even if it's lesser than 1 centimeter in an hour, in 2 hours, you can wait for 2 hours for 1 centimeter dilatation. And if it's lower than that, then you need to go for your interventions. So the interventions which is advised by the RCOG is amniotomy if the delay is diagnosed. After amniotomy, wait for 2 hours before starting your oxytocin. And after oxytocin, wait for 4 hours of oxytocin usage, and then review her and then decide that she's having a slow labor or a dysfunctional labor. Then you need to go for a cesarean section. And the second stage, according to the RCOG, you can wait for 3 hours. But after 2 hours in a primary, you have to have an evaluation done. You cannot wait thinking that she will definitely deliver. And in a multipara, you can wait for 2 hours for the second stage of labor. And what the Williams Obstetrics says, according to its Parkland Hospital protocol, is even after the American College guidelines came, they still define active phase as 3 to 4 centimeters dilatation. Pelvic examination can be done after 2 hours after you've diagnosed active phase. If there's no cervical dilatation, that is not even 1 centimeter in 2 hours, then you do an ARM, wait for 2 hours after an ARM, and still if there's no cervical dilatation, put an intrauterine pressure catheter, find out whether it's really a slow labor, and the contraction should be at least 200 Montevideo units, wait for 3 hours after ARM, and then you diagnose that it's an inadequate uterine contractions and give oxytocin. If adequate uterine contraction and still the cervix is not dilating, then you diagnose arrest. So the dilatation, according to the Parkland protocol, should be at least 1 to 2 centimeters. So it is similar to the active management what Driscoll said. But in the American College, you can wait for 2 hours for 1 centimeter dilatation before diagnosing arrest. Second stage arrest is actually 3 hours with epidural and 2 hours without epidural. It's not 4 hours as in the American College. So, because there's something that we can take home, that we need not feel bad if there's some dysfunctional labor, it's not your fault, because there was one study which wanted to identify the genetic contribution to labor arrest, and it was done by a person called Charmila in 2013. He compared the muscle DNA of women who underwent the first cesarean for labor arrest and those who had the first cesarean for fetal heart rate concerns or fetal malpresentation. No one in either group were induced. Women with labor arrest, that is, who did not have fetal heart concerns for cesarean or fetal malpresentation, had actually different genes for muscle contraction, muscle inflammation, and how the muscles respond to low oxygen levels during contraction. So the study actually suggests that there are some people with labor arrest who have genetic differences that will affect the muscle cells of the uterus. So even if you give your maximum management, you may not be able to deliver many women, some women vaginally. So the messages which I'm putting as a question mark is, should we diagnose active labor at 4 or 6 centimeters? Do it with caution, whatever you diagnose as. And please plan your intervention, execute it correctly. Do not rush for amniotomy or oxytocin augmentation. Think twice before giving epidurals. And please consider the local population before you go into managing your laboring women. Don't take Western guidelines if it's not going to be applicable to your local population. That's what I would think. And last but not least, we need the astrological benevolence. The gods have to be with us if we are going to have a mother who's delivering safely. That's what the situation is there now. Thank you so much for the opportunity. Thank you.
Charmila, that was a wonderful presentation. Right, it took me back almost 30 years when my dissertation was active management of labor, and I had studied all these things. O'Driscoll was like a hero for me then. We did use the active management of labor augmentation by oxytocin and had some wonderful result. I totally agree with you about the second stage. What is more important is we have to monitor the progress, and we should not forget that the second stage is divided into two. One is pelvic and the other is perineal. Right. So perineal part is the one when the patient has the urge to push, and when the patient says that she wants to push, that is the time we should ask her to push. Many times what happens is, especially with the youngsters, once the cervix is fully dilated, whatever may be the station, they start asking the patients to push, and that is not the right way to manage labor. And of course, it may be worth considering active labor from 4 centimeters to 6 centimeters. Of course, this will have to be individualized. You very nicely brought out about the genetic theory also, and sometimes I also feel that it is the anatomy which is different in some patients, because many a times we haven't observed that when we take up a patient for emergency cesarean section, even in a primary gravida, at times the lower segment is very thin, which is not a usual occurrence, and we do not expect unscarred uterus to be really thin. So there has to be some anatomical variations also, which could be responsible for such cases landing up in cesarean section. So thank you very much once again for a presentation, and I really enjoyed it.
Thank you. Thank you.
Yeah,
we are all hardcore obstetricians at the.
Absolutely. So I was enjoying each and every slide of yours because it is really very close to my heart, and I really enjoyed these presentations. So thank you, Charmila, and thank you, Pratik, for having us here. And sincere appeal to all the viewers, Dr. Arun Barua, who's chairing with us. He's a contestant from the East Zone. So if you've not voted, please vote for him. We have Dr. Girija Wagh in the audience, who's a candidate from the West Zone. So she's also a worthy candidate. So please do vote for all these people who have worked for Foxy for a very long time. Thank you very much.
Thank you.
I think Dr. Arun wants to say something. Please, go ahead.
I just want a little clarification from Charmila, because you have put 2 query marks with epidurals. Are you epidurals?
No, the thing is, when you give epidurals, your monitoring becomes very intense, and you cannot allow her to walk about and have a much more smoother progress, and your everything is delayed. Your first stage, your second stage. So when you want to avoid a dysfunctional labor, give her the other support to care. Try to avoid an epidural, but if she's very insistent, you can always go for it. That's why the 2 question marks. Because I always grade the person who's having an epidural. This staff monitoring and our monitoring becomes much more intense.
My take on this could be little different because
Yeah.
lot of the C-sections today are being done for the fear of labor pains. So I've been able to convert at least 50% of those into normal delivery once you bring in epidurals for their minutes. So it has to be on a case-to-case basis probably. But yes, your point is very well taken, and that's also should be judgmental from case to case. But I am giving my experience that I've been able to convert at least 50% of those who were eager to go for C-section with epidurals. I've been able to revert back to normal delivery, and they really get to me, and they stuck to me for a long time, even now.
Yeah, with epidurals you have a smoother progress definitely, but in our population, that is Trichy is basically a smaller city. Here the motivation to have a vaginal delivery is so much, and they don't mind the pain actually. So many times we were able to talk with them, and you said we individualize. But a IT professional comes, I don't even talk. I'll straight away say your epidural is ready for you. But if it's going to be a person from a smaller village, she's very motivated, and many are very fit also. So we don't want to give them epidural and prolong that labor, which would have been much easier than going through an epidural. That's why. But as you said, the individualization matters. You cannot take, each person will not be the same as the other. That's going to be there. One size will never fit all. That we have seen in labor.
Fully agree with this.
Yeah, Charmila, can I make a comment
Yes,
if you allow?
Yeah.
I'm of the same opinion as Arun, because the observation that we have had in our hospital in Pune has been the labor progresses rather rapidly after administration of epidural. In fact, we've not seen delayed labors at all. Number one, we did study our patient, and we realized that the C-section rate, which was about 30% in the hospital, came down to 25% as the number of epidurals increased. So it does have a definite role to play in women who do not wish to bear the labor pain. And as Arun said, there are some women who are either scared of vaginal delivery or whatever. I think epidural definitely helps them to relieve the pain, and we can definitely make an attempt for a vaginal delivery. And I especially feel so when you're attempting a VBAC. We many a times counsel our women, because many a time they've not experienced labor pains in the first pregnancy, and especially if they've had a elective C-section. And if you are attempting a vaginal delivery, it is definitely much smoother. And mind well, even if there is scar tenderness, it is not masked by epidural. So it is worth considering epidural for such women.
Counseling for epidural, levonorgestrel, IUD is all very difficult for us here, because they feel they're doing something intervention when it's supposed to be very natural. But there are women who actually, when we tell them and they accept, we give epidurals. We know it works much better. But in a population like Trichy, we find it very little difficult. When I was in a multi-speciality, I found it much easier to counsel those women. But in my practice, it's very difficult. That's why I put up that question mark. Just for individualization.
I'm sorry to interrupt this very engaging discussion. There are a couple of questions from the audience. There are two for Dr. Sujata Dalvi, our first speaker, and two for Charmila. So since Sujata Madam spoke first, I'll just take those first. This is from Dr. Chandrakala Maran, and her question is: RH negative mother, husband is RH positive, has had recurrent bleeding episodes. Should anti-D prophylaxis be repeated?
Yeah, that's what we say, that if at all it is more than 12 weeks or whatever it is, antenatal prophylaxis needs to be repeated.
Thank you, ma'am.
So every 12 weeks you have to repeat it, provided she is bleeding continuously.
And there is an interesting question here from Dr. Jayalakshmi. If the husband is RH negative and consanguineous, does it matter?
No, it does not matter as such.
We wouldn't do genetic studies anyway.
No, we wouldn't do it if he's RH negative.
This question is from Dr. Bhanumati Sharna, and the question is: after the head is visible, I find that the pain stops despite the oxytocin drip of 5 units and the patient stops pushing. What do I do?
That is the $1 million question or $100 million question. The thing is, just wait for some time. Don't try any, because if the contractions are going to be good enough and the descent will just stop for a period of time, you can just quote the American college and say, I'll wait for 3 hours. You're
So
not going
probably
to...
what we would do in practice is throw away the old pint and make a fresh one.
Yes, yes.
I'm
that's
not going
also...
to comment on the contents of the fresh pint. I leave that to your imagination.
Yeah.
The next question is from Dr. Shikha Singh, and she's saying that the WHO partograph starts at 4 centimeters dilatation. So thanks to your talk today, do we need to revisit that?
No. It's around 3 to 4. You can have it 3 or 4, but it's about around 4 centimeters. WHO is 4 centimeters.
So I think those were the only relevant questions that we had, and some of those were actually repetition compared to what the speakers had already said earlier. I'd like to place on record my gratitude to two very fantastic speakers, and we were privileged to have Dr. Pushpa Raju, Dr. Amla Devi, and Dr. G.P. Madhavi here with us today, the presidents of the societies that are collaborating with us today. I would request the chairpersons to give some final closing comments before we proceed for the panel discussion.
Parag, you can go ahead.
I've already spoken enough, so you can give.
Pushpa madam, any feedback, ma'am? Pushpa madam, please unmute yourself, ma'am.
One question to Sujata. Is it mandatory to prescribe antenatal prophylaxis in all RH negative mothers? Is it mandatory?
Yeah, it's always better to give it, because sometimes you don't know what about the feto-maternal hemorrhage in the first and the second trimester. Though RH antibody titer you may do it, but if it is negative, then you try and repeat it, it still comes negative, but sometimes you don't know. So it's always better to give antenatal prophylaxis so that you don't have to find out how much is the feto-maternal hemorrhage after delivery. So 2 doses is sufficient enough as such.
So that dose is 150 microgram or 300? You said
no, we give 300 at 28 weeks and 300 after delivery.
Dr. Arun, you'll be very surprised when this concept first came out in the 1990s. I was a resident doctor and my lecturer was Dr. Sarita Balerao, who is currently the vice president of MOJS. When I told her about this concept, she said there must be something wrong. You go back and read up because I don't think the RCOG will recommend empirically to give everybody anti-D at 28 weeks. But I think it's become established.
Yeah, and there's more chances of feto-maternal hemorrhage in third trimester. That's why you give it at 28 weeks and then one after delivery. That's all. So it will compensate for both the things.
I think we really revisited RH compatibility after a long time.
There is some echo. I think we need to switch off whoever has that echo. Backend team, please look at it.
So thank you with you all on this session. As Dr. Charmila said, in our place also the epidural concept is not very popular, and patients are very not very fond of this epidural analgesia because of the as spinal anesthesia. They are very scared of this back pain and all. Even in spinal anesthesia, they say we get back pain. So they are very scared of this spinal epidural analgesia. So they are prepared to bear the pain for the of the labor. So they are not fond of this epidural. So they are prepared to bear the labor pains. So we are very finding it very difficult to convince them for the epidural analgesia. So for labor induction, we find it very difficult to convince them, as Dr. Charmila said. And in this COVID pandemic, we have to induce them at 10 to 8. Lots of patients are coming for induction at 38 weeks, and the cervix is very unfavorable. We have to put them for a long period in labor. So we are finding it very difficult to keep them in labor for a long time. So that's also a very difficult time at this period of time.
Thank you, ma'am. Any further comments, or can we move to the panel, Dr. Charmila?
Yeah, we'll move on.
Okay. So my gratitude to everybody, and Before Parag takes his leave, I have to also place on record my gratitude to the ICOG office bearers, Chairperson Dr. Mandakini Meg and Secretary Dr. Parag Biniwale for granting us an ICOG credit point. I normally do that at the beginning of the program, but since Parag is here in person, I'm doing it during the middle. Can we have the slides for the introduction of the CVs, please? Requesting everybody who is not a panelist now to please mute themselves and switch off their video. So we'll have a quick panel discussion. This is on recurrent pregnancy loss, and we are privileged to have with us several leading lights from the South. The first of these is Dr. Papa Dasari. She has an undergraduate teaching experience of 32 years and a postgraduate teaching experience of 25 years. She's a former HOD of obstetrics and gynecology, and she has been IMA Vice President way back in 2009, JFA Vice President 2008 to 9, Pondicherry Chapter President OGASP in 2018. A multitude of awards to her credit, and she is a very senior respected figure in the South from Jipmer Pondicherry. Welcome, madam. Next slide, please. Dr. Kiran Mai is well known to all of us who have visited Hyderabad for any of Dr. Shanta Kumari's conferences. I think she is the right hand of Dr. Shanta Kumari, our president-elect of FOXI. She is also an associate professor at Usmania Medical College in Hyderabad, vice president of the Hyderabad Society 2019-20, scientific convener of AICOG 2011 when it was held in Hyderabad. She's also been the Kamini Rao Yuva FOXI orator in 2013, has several other credits, as you can see from this slide. Unfortunately, I will not be able to read all of them out, but we have a very distinguished personality in our midst. Welcome, Dr. Kiran Mai. Next slide, please. Dr. Vidyalakshmi Pradeep is a consultant obstetrician and gynecologist at Krishna Hospital. She is an MBBS from Chennai from the 2001 batch. She is an MD OBGYN from Kathmandu University, DGO from Amrita Institute of Medical Sciences. We had FESI in our program yesterday along with the Cochin Society. So I mentioned that to him in passing and he remembered you. And she is also certified in genetic counseling, FMF certified for NT scans. Her field of interest is high risk obstetrics and fetal medicine. Welcome, Dr. Vidyalakshmi. Next slide, please. Dr. Dibendu Banerjee is our national faculty today. He is the president of the Bengal Society 2019-20. He is also a consultant gynecologist at Bhagirathi Women and Child Care Center, Columbia Asia and EMRI. He is a member of the ART cell of FOXI and a very distinguished and learned personality. Welcome, Dr. Dibendu Banerjee. Next slide, please. We have Dr. Jyoti Banglowala with us. She is the Joint Secretary of the Indore Society, a private practitioner since 28 years and a senior consultant at the Christian Hospital and Gokuldas Hospital. She has a keen interest in high-risk pregnancy and adolescent health. Her special fields of interest include awareness camps with NGOs, and she's an executive member of IAEC. Next slide, please. Dr. Shazia Monis is the secretary of the Muradabad OBGYN Society. She is an MBBS from KGMC Lucknow and an MS from Meerut. She's worked as coordinator for the FOXI project on anemia and menstrual hygiene for slums in the urban areas of Muradabad for 2 years. She's a director at Hope Hospital in Muradabad, active member of that society, and has held several positions in the executive body there. Welcome, Dr. Shazia. Next slide, please. Dr. Jyoti Saigaonkar is a senior OBGYN, endoscopic surgeon and infertility specialist practicing in Thane since the past 20 years, director of Dr. Saigaonkar's Hospital, attached to several hospitals including Jupiter, Kaushalya, Curie and IVF Care Hospital. She's a postgraduate from KEM and Wadia Hospital, has a DNB, active member of several organizations, has presented numerous papers and posters, has also won the Shirin Mehtaji Award and the DK Tank Prize for Best Paper, actively associated with an NGO and a strong propagator of menstrual cups. She is also in her free time a well-known singer with a group called as Saptasur. Thank you so much for joining us. If I may be permitted to share my screen now, we will go on to the panel discussion. Just bear with me for 30 seconds while I try and sort that out. All right, I think slides are visible. Panelists?
Yeah, it's
Yes,
visible,
yes,
visible.
yes.
Fantastic. Thank you. You can unmute yourself now. Yes, so the mouse doesn't work, but the keyboard does. Welcome to all our panelists. This is a straightforward, simple discussion on
मला
recurrent
डिस्टर्ब नको
pregnancy loss. And I'd like to start with a
त्यांच्याकडून करायचं पण आता मी काहीच करू शकत नाही माझे लेक्चर्स
yeah. So I think we have your undivided attention now, so we shall proceed. Usually, the main problem with life's conundrums is that we don't bring to them enough imagination. If you see recurrent pregnancy loss, there are a plethora of guidelines from many of the international bodies, including ESHRE. This is the updated guideline from 2019. There's also an ASRM guideline from 2012. And also there are several other RCOG/NICE guidelines which are happening, formulating, and probably because of the COVID pandemic, they have got delayed and they will be with us very soon. So let's start by asking a very practical and simple question, and I'm going to address this to maybe Dr. Dibyendu. Sir, in your 20-25 years of practice, do you find that recurrent pregnancy loss is still relevant in day-to-day practice? Is it a niche area or is it something of relevance for the common obstetrician gynecologist?
Yeah, it's basically very relevant, and it has always been so, and more so now. I believe it's more relevant because people are conceiving at a later age. People are more tech savvy. People read about recurrent miscarriage. Even after one miscarriage, they come to you and question you. So it is far more relevant than it was 10 years earlier.
And in your experience, sir, do you find that the incidence is more or less the same, or is it more because people are now willing to come forward to get investigated much more and maybe a little earlier?
Yeah, the incidence, I believe, if you go by textbooks, there has not been much of a change. But if you go by practical experiences, definitely there has been a rise. The rise may be because the people are more or less, more people are coming forward for advice at an earlier stage, even after a single miscarriage. They are concerned and they want to investigate, and not only investigate, they want to know what can be the probable cause. A very difficult question to the gynecologist.
Thank you, sir. I think that is very nicely highlighted by you. And I'm going to build on what you said just now and ask Dr. Vidyalakshmi ma'am that the guidelines sometimes are in conflict. One guideline says you investigate after 3 losses. That is what we were taught 30 years back. Today, they are saying you investigate after 2 losses. Maybe 10 years from now, when you and my children are practicing, it will say investigate after 1 loss.
After one loss.
So the goalposts are moving all the time. Do you find that because of these changing attitudes, we are over-investigating?
You're probably correct, but where do you have a limit? I think that everything, like Madam said earlier, Dr. Charmila said this word, that one size cannot fit all. So it's the same story with investigating for RPL. One size cannot fit all. Every patient requires an individualization. So we have lots of women who are choosing to conceive late in life. We have women who are more career oriented or due to various reasons, they have chosen to have one single pregnancy. So it's us to, earlier it was like 2 children per family. Nowadays it's 1 child per family. So there's 1 child that they want. They are wanting it late in life. They don't have a long, their biological clock is ticking. So they're worried about it. In this situation, where do you say, okay, this is the limit. I'm not going to investigate further because it's going to cost you more. Or this is probably not going to yield you good results. I don't think there's a limit. Instead, we have to individualize it. If a person is in a younger age group, she has a longer reproductive life ahead of her, she's economically a little bit poorer side, perhaps we can stop at a particular level. We have to form our own protocol for that. We cannot make it one size fits all for everybody.
Thank you, ma'am. Dr. Dibyendu wants to add something. Yeah, please go ahead, sir.
Pratik, there has been a trend amongst us. I would rather bring in a bit of criticism. We are tending to investigate too early and too much.
So I think there are two very good opinions here from the panel. One feels that we investigate a little too much. One feels that we should individualize.
Too
And I would,
early and too much. The
yeah.
dish is too early and too much.
So we'll address this a little bit later after a couple of slides, and we'll come to why this question was posed in the first place. Is it just to throw a cat among the pigeons, or there is some scientific relevance to it? I'm going to now bring Dr. Kiranmai ma'am into the discussion and ask her. We actually use these terms very interchangeably. Recurrent pregnancy loss, recurrent miscarriage, repeated abortion. There are different terminologies that you will see in textbooks over the past 25, 30 years. Are they all the same? Do they mean the same thing? Or are they different scientific entities?
I think the recent HRA guideline has made this quite clear, I think. So recurrent pregnancy loss is the preferred terminology for, and the definition is 2 losses, and 24 weeks is the cutoff. And all words like spontaneous abortion, then other things like biochemical pregnancy, all these things have to be discouraged. And the word is most preferred is recurrent pregnancy loss, but they can be used. A recurrent miscarriage is mostly intrauterine pregnancies, loss of confirmed intrauterine pregnancies. It has to be, isolated to that particular entity. That is one thing. But most of the times we see that they are interchangeably used.
Absolutely right. Most of the time we use most of the scientific terminologies, yours truly included, very loosely and interchangeably. But it's important when you are doing a scientific study or you're comparing different outcomes to ensure that what we call inclusion criteria and definitions are very clear and strict. If you're comparing apples to apples, then your paper will actually get accepted into the journal. If you're comparing apples and oranges, it will go straight into the dustbin. And this is why having a clear cut definition is important. Thank you so much, ma'am, for bringing that out. Let's go to the cases. This is the 30-year-old lady who's married since 4 years. As is common, she used contraception for the first 2 years after marriage. She's conceived spontaneously 1 year back, but she had bleeding in the second month, had a miscarriage before any treatment could be instituted. Then had a second pregnancy again 3 months back. At that time, she went to the doctor. Ultrasound was done. There was a fetal pole, but no cardiac activity at 7 weeks. She did a follow up ultrasound. There was no cardiac activity. It was declared as a missed miscarriage or a missed abortion. The doctor offered her two options, a surgical evacuation or a medical method. Being scared of surgery, she preferred medical option. Dr. Jyoti Bangbolwala, she's come to you and she has a host of questions. For the sake of simplicity, we are going to rotate all these questions amongst all our panelists. So since she has a lot of queries, let's take all of them one by one. She's asking Dr. Jyoti, Madam, what is the cause of my repeated miscarriages? Why do you think I'm not able to have a baby? What is the most common cause?
Yes. The obstetrician should have a answer always evidence based, and we have to only say that all of the pregnancy, most of the causes are chromosomal, and she's only having 7 weeks pregnancy, and that too of missed abortion. So we have to console her only. That may be due to chromosomal abnormality, and first of all, listen patiently to her. There is no history. If there is no history of any other diseases like diabetes or APS or any endocrine abnormality or thrombophilia or anything, no, only if we should not approach her like a basket approach. Individualized approach should be there, and first of all, listen carefully what she is saying, and not only the women, also the partner, the couple as a soul should be treated. And just counseling is, in the first visit, counseling is the only thing. And counsel her about the chromosomal abnormalities of the partner or herself, and let her go for the third time. I will not prefer to give her a basket approach of all the things, the torch and chromosomal abnormality pattern or malfunction.
So we'll come to the investigations in just a minute or two. I think, Madam, if I can summarize what you're trying to say is that this lady probably in the first pregnancy has not received treatment. So we don't know for sure whether that was a pregnancy or not. But the second case, she definitely had a confirmed intrauterine pregnancy. Only it appeared to be an anembryonic gestation or an early loss. which usually points to genetic or chromosomal issues. That's the most common reason. Having said that, there are a variety of other causes. Yes, ma'am, Dr. Kiran.
Yeah, continuing on what Dr. Jyoti has said and also what you have given a clue that it could be a genetic. So at this point of time, maybe we can tell her that there could be one of the causes being genetic, and it is time that she gets investigated in this angle along with a basic profile, because
Yes, ma'am.
in this time and era, we cannot generally say that go for third and let us see after the third. So my take would go for some investigations baseline and again check for a genetic angle, because she's not yet aborted and she's preferring to go for a medical method. I would suggest if I have to go for a POC genetic study, better go for a surgical this thing and then go for a POC, not karyotyping. I think the discussion will develop later, but I would suggest this at this point.
So we'll come to genetic investigations a little later in a couple of minutes. She's come to Dr. Jyoti now. We are assuming that Dr. Jyoti is now the consultant in charge, Dr. Jyoti Saigaonkar. And she's asking you, madam, is it because of my age? Was I wrong to use contraception for the first 4 years? Is it something that I should have avoided? Am I at fault? Am I too old to have a baby?
I don't think the age 30 years is too old to have a baby. I think it's the right age to have a baby. Okay, if she was married at the age of 26 and was using contraception for the first 2 years, I feel that's okay. Unless and until she has a history of premature ovarian failure, or for that matter, premature menopause in her family, which she is specifically aware of, that is the time, yes, I would consider that she would have, had her early pregnancy, the time she got married within her 2 years of marriage. But otherwise, no, I feel 30 years is not a very advanced age to have a pregnancy.
How would you counsel this patient? How would you counsel this patient regarding age-related risk of having miscarriage?
Fine.
Further building on what you said.
Okay, fine. I would just tell her in a very simplified manner that a woman has a biological clock which ticks pretty early, as compared to a man. And the ovarian reserve, the number of follicles which a woman has at birth, drastically, when she attains menarche, she almost has half of them, and rapidly they keep on reducing. And that is how she attains menopause by the time she reaches 45 and above. So that is the very reason that every woman should has a reproductive age, and during that period of time she has to really have her children, so that how would I say that reproductive age limit is not crossed. So normally we always advise to have 1 or 2 children by the time a lady reaches maybe 30-32 years of age, and preferably avoid pregnancy once she is about 35 years of age, because of the diminished ovarian reserve, because of the risk of anomalies and Down syndromes and aneuploidy and related anomalies. So I would say that this is how the reserve keeps on reducing, the quality of the ova keeps on decreasing quality wise, and therefore have a baby before you complete maybe 35 years of age, or
So
your
what
AMA starts
the
falling.
nice guideline says that women should be sensitively informed, and sensitive means
Yeah.
non-judgmental. It's a pseudonym that you be non-judgmental. Do not try to criticize whatever their decisions are, and inform that the risk is lowest under the age of 35. Having said that, it is also important to emphasize that the risk is much higher and significantly higher once they cross the age of 35 or 40, and that they shouldn't leave it for too long. Though we as doctors do not make that decision for them, that decision has to be made by the patient. Now, we always keep talking about maternal age, saying that maternal age and genetic issues are factors. Dibyendu sir, in your experience, is paternal age also a problem? Can it be an issue? Can it contribute to genetic anomalies?
Age definitely, the age affects the quality of spermatozoa. You get a higher incidence of fragmented sperms. Not only that, it is basically the habits of males, especially if you consider smoking, which definitely interferes with the quality of spermatozoa, the motility, and the antioxidant therapy is required in many of these cases. Age definitely, actually we always bias towards males. Males, we always take it that
That is why
males,
the question is posed to a male.
the males are never at fault. They're like, whenever a patient comes to me for it, not for a RPL, for an infertility, I always stress that you get yourself tested first, because it's almost 50% of the time that we see males are at the wrong side. And as of now, as of today, we can see that the quality of spermatozoa all over the world is coming down. The quality is coming down, and maybe in future we'll have further studies that the quality of spermatozoa has got the effect on the quality of the progeny.
So usually we don't recommend these expensive tests because they are neither
A
sensitive
microarray,
nor
yeah.
specific. But in certain selected cases where you feel genetic mutations are being passed down from the paternal side, you're well within your rights to try and do these tests. It's beyond the scope of today's discussion to talk about it too much. I just wanted to draw some light on this and emphasize that recurrent pregnancy loss is not a problem only of women or mothers. It's a couple problem, just like infertility is a couple's problem. It has to be approached as such, and that has to be transmitted into your patients, the couples who are coming to you for treatment, and it's a societal problem. It's a social issue.
And you've done well to single out the odd man out here.
I try and be fair and balanced everywhere, wherever possible. I'm going to ask Dr. Shazia the next question. Now, the patient is asking you, ma'am, what is the prognosis for me? I've had 2 losses in a very short period of time of 1.5 years of trying. Should I try immediately? Will I be successful? What is the chance that I'll be successful in having a live baby at the end of 9 or 10 months?
Yes, sir. As she is only 30 years of age, first of all, we should explain her and counsel her that she should not lose hope that after 2 losses, she can have a successful pregnancy. And after doing the routine investigations, we can rule out the cause, what is exactly is the cause, whether it is genetic, whether it is due to autoimmune thrombophilia or any sort of endocrine or metabolic disorder. Once we rule out the causes, if suppose it is not a genetic and a simple treatable cause, then of course at 30 years of age, she does have a very good chance of a successful pregnancy. But we should also explain that as she will have increased number of miscarriages, the chances of successful pregnancy go on decreasing with increasing number of miscarriages. So she, after the routine investigations which are essential, then of course she can go in for a normal conception, and she should hope to have a good pregnancy. And 30 years not that advanced age that she can't have a successful pregnancy.
So this brings into light the initial discussion that we had at the beginning, whether we are over-investigating. If you look at this age-old study from 1997, published in Human Reproduction, it says that even after 3 consecutive losses, the chance of having another loss is 29%. After 6 losses, you still have a 50% chance of having a live birth. So which means very simply that patients just need tender loving care, they need time, they need patience. You need to identify if there is an etiology that you can treat. The vast majority of patients, as we saw earlier, 50% plus, it is idiopathic or what we call unexplained recurrent miscarriage. Yes, ma'am, please go ahead.
So besides the medical factors, we should also look into the other epidemiological factors which we should train the patient from now only. We should also take into the history of personal history, if she's having any history of smoking, excessive caffeine.
We're just coming to that in 2 minutes. 2 minutes, I'll bring you back into the discussion in 2 minutes for that. And there's another much more recent study published in 2019, which says that out of 300 women which were followed over 6 years, 82% conceived successfully and 73% of them had a live birth. And these are patients who did not have a defined etiology. These were unexplained recurrent miscarriage. So the age-old teaching which we had when we were students, that you need to be patient and you need to be empathetic and transmit that to your couples, I think is still very relevant even today. The next question, yes?
Actually, 33% are always the unexplained etiology.
Absolutely.
So we have to tell the couple they should try, and there are fair chances of the successful pregnancy outcome.
I'm going to ask Dr. Kiranmai this next question. The patient is thinking that there's something unclean inside her. There is some infection. Maybe it is related to the candidiasis which she had, for which she came to you for treatment. Is it possible that there was some ascending infection, caused damage to the uterus, and that is why she's having repeated miscarriages? She's asking Dr. Kiran.
But I mean, considering that she has had an embryonic pregnancy, so I would say that it might not be, but there are infections which are responsible for the RPL, the bacterial vaginosis, and then these are all the organisms which you have here clearly so, but they're not responsible for RPL. But endometritis, subclinical endometritis, is, considered by many as one of the causes of RPL. And I would like to say here itself that torch has to be gone from the causes of RPL.
Thank you. I think in 2 sentences she summed up everything. If at all infections do occur, they are more related to infertility, like an endosalpingitis or an endometritis. They usually cause either ectopic pregnancy or they cause recurrent implantation failure respectively. These infections are not responsible for recurrent pregnancy loss, and the same is also true for torch infections, as she's rightly pointed out. Therefore, we don't do these tests anymore in investigations of recurrent pregnancy loss. The only place where we do these tests is when somebody has acute onset high grade fever during pregnancy and when you want to rule out an acute infection in pregnancy. Therefore, we will not talk about this anymore. So let's come to the tests now. And here I'm going to bring Dr. Vidya Lakshmi back into the discussion. In your experience as a fetal medicine consultant, ma'am, what would you recommend as tests in the interval period for these patients?
Sir, I would very much like to be a fetal medicine consultant, but I happen to be a general obstetrician and gynecologist. Anyway, regarding the test that I would recommend, one of the clues that I should be using is the timing of the miscarriage or the pregnancy loss. So here, if we note, this lady does not have any previous past history, and which is relevant, and she has had 2 first trimester pregnancy losses, both probably less than 6 to 7 weeks of gestation. So this is the kind of situation where I would focus more upon chromosomal abnormalities in the parental chromosomal abnormalities or any anatomical issue, mainly a septate uterus, and perhaps immunological causes. Like we can discuss it further as we go into the topic. And then, of course, the endocrine and metabolic causes. So especially metabolic causes like diabetes mellitus, which has been very well studied. So these are the things that I would focus on. These are just general guidelines. I guess the subsequent questions will go into the details now.
I think you've summarized it very nicely. And if you look at the ASRM guideline from 2012, there are very few tests which are recommended, which are based on good clinical evidence. And some of these you can see listed here. These include the simple hormonal investigations, a screen for gestational diabetes or frank diabetes, which does pop up occasionally. Karyotyping we'll be discussing extensively in just a minute or two. Look for abnormalities in the uterine. Look for abnormalities in the uterus using whichever mechanism you feel is preferred and what is available to you. In more of the metro cities now, we resort to HICOSI rather than the traditional HSG. And we will come to APLA and all those tests at the bottom towards the later part of the discussion. These are evidence-based tests. There are a lot of other tests which are available, which are done, which may or may not be relevant. They may not be sensitive or specific, so they are not generally recommended by most of the major guidelines. So since we are discussing genetic abnormalities and Dr. Kiranmai had started the discussion, I'm going to ask her to continue here. And what do you think are the most common abnormalities or genetic abnormalities which are responsible for first trimester losses?
Mostly it could be aneuploidies, then trisomies, then maybe translocations, kind of translocations, both Robertsonian and balanced translocations. And these are all some of the common chromosomal abnormalities which can cause.
So as you rightly pointed out, it is the products of conception wherever possible, which should be the first stop where genetic assessment is considered. If the patient comes to in an interval period, of course, we have lost that opportunity and then we have to do a parental karyotype.
So this
Having said
patient
that,
doesn't, yeah.
No. Is the parental karyotype required? No.
No, it
No,
is not
not
required.
really. Because
It is
most of these
conditional.
miscarriages are mutagenic. They have mutations. So
After POC, if required, then we can go for
if there is an abnormality in the POC, only then you go in for a parental karyotyping. Otherwise, I think we would be overshooting. That is my
That's
opinion.
not true for all the abnormalities. If the product of conception is showing a mutation, for example, you don't need, it's a diagnosis of exclusion. You don't need a parental karyotyping in these cases. Only if you see a monosomy, a trisomy or a monosomy, you got to think about a Robertsonian translocation or a balanced translocation in the parent. Otherwise, we don't need to do a
Absolutely. Totally.
So I think
Karyotyping is a conditional thing, not a strong recommendation.
true. And again, you'll find that the vast majority are aneuploidies. And if you look at the history, this is very important. If it happens in the first 5 or 6 weeks of life, then the incidence of genetic abnormalities is 90%. If you cross 6 weeks and go to 8 weeks, then it's only about 50%. And beyond that, it drops significantly. And this is why it's important for us to spend those extra 5-10 minutes going into the history, identifying whether there was an intrauterine pregnancy, whether there was an ultrasound done, whether all those other things that we look for on first trimester scan were visible or not. I think we've tackled this particular issue quite well here, and I'm not going to go much into these details because that's been very beautifully brought out by all the panelists.
One important, I think all of us must be knowing that the POC karyotyping is not of much use. Okay, generally, initially, in the past few years, we used to send for karyotyping of the POC. Rather than that, the CGH has come up a long way.
Correct. But CGH is unfortunately not available widely.
Everywhere.
And it's also
but
quite
sending POC for karyotyping also is not much, it doesn't give little contamination.
And then I think it is beyond, it's unnecessary to say that if you find that there is a genetic abnormality, then please refer to a genetic counselor. We often take it for granted, but during the course of a 1-hour panel discussion somewhere, it has to be said in black and white that don't presume that you can guide these patients because we are not experts in genetics, and they should have at least one opinion on paper, especially if they have one of these rare, balanced translocation and stuff like that. Often you will find that
legally it's very important.
Exactly. Often you will find that you will get some of these rare balanced translocations in an occasion parental karyotype, and the patient is running from pillar to post trying to find some answers. And he's visited probably 10 or 12 gynecologists, and nobody has referred him or her in the past to a genetic counselor who can give a definitive plan forward and a path forward. So now, since we've talked about the common issues, what I want to ask my panelists is, what simple guidance would you offer this couple? Starting with the pre-pregnancy counseling, and then when she is pregnant, what are some of the basic and common medications that you would like to institute? Shall we start with Dr. Jyoti Banglowala?
Yes. If patient comes to us for the pre-pregnancy counseling, so routine blood checkup, and if she is underweight, tell us to gain some weight. If she is overweight, so tell us to come for a ideal weight. Basically, more than 27 BMI, it is difficult for gaining the fairer outcome of pregnancy. And if there is more than 30 BMI, it is going to be an infertile couple. And if there is a habit of smoking, alcoholism, or more of the caffeine or tea consumption, that also to be taken care of. And if the patients are doing vigorous exercises, nowadays girls and boys are coming with a lot of weight trainings and exercises that tell them not to do the sort of exercises. Routine checkup, routine thyroid, routine prolactin levels, all sort of is the basic checkups. And 3D USG, I will recommend 3D USG for the anatomical aspects. If patient is coming to us for pre-pregnancy counseling, if patient is coming to us after a miscarriage, then asking just like this case of 7 weeks pregnancy, I will going for only for chromosomal abnormality and the anatomical aspect of the uterus. And the basic treatment like a hypothyroidism or diabetes or APS, nothing more.
Yeah, so we'll come to those individual cases a little later during the discussion. I want to ask Dr. Shazia, madam, what treatment would you suggest when she gets pregnant again?
Okay, sir, as she is conceiving for the third time, besides folic acid, I would also like to give some luteal phase support. We should not take any risk because it has been seen that progesterone support should be given to such patients, and she should not be advised strict bed rest, only minimal activities which she feels she can do. And that's it. And routine after and get all the investigations done routinely as it is necessary.
I'm going to ask Dr. Jyoti Saigaonkar, what do you think is the role of progesterone? Is it deficient in Indian women that all these drug companies are forcing it down their throats? Don't we have enough progesterone in Indian ladies already? Why do we need to supplement? क्या जरूरत है?
See, more so ever when we don't have a very definitive treatment protocol for all these women of RPL, okay, whatever we add on to the basket always adds on to the benefit, okay. So now as we talk about the advancing age and the deteriorating quality of the ova and hence the corpus luteum, that is where the role of progesterone always comes in, and it's not it's not harming at all whatsoever, okay. So I would definitely, there's always a beneficial role of natural micronized progesterone. And I strongly feel that supplementing that in the first trimester, at least up to 12 weeks of gestation, definitely plays a role in preventing a lot of abortions. And apart from that, even we have dihydrogesterone, which is also an immunomodulator, is what they say. Okay, so I regularly prescribe both these molecules and I find it very beneficial.
Yes, Dibyendu sir, please go ahead.
Yeah. The basic thing is, other than the support to the endometrium supplement that progesterone that is being produced by the corpus luteum, it is the only major important part is immunomodulation. And if you are thinking about immunomodulation, it's the type of progesterone that you want to use, the route of the administration, which is more important.
So especially when you consider a background of recurrent miscarriage, you will find that there is an imbalance between Th1 and Th2 helper lymphocytes as they are called. And because these patients have greater abortogenic shift with both the cytokines as well as the natural killer cells, it is recommended that in the first trimester at least to have a helpful shift towards positivity and continuation of pregnancy. Progesterone can help. This theory is proven quite clearly, and you will see that the natural killer cell activity goes down. All the beneficial progesterone action will help the Th2 continuation to continue. In fact, there is a person of Indian origin called as Dr. Raj Raghupati. He comes to India quite often, and he's spoken about this. He's done extensive research in this, and you will see his papers quoted extensively in modern literature. Let's go quickly now to the individual cases. I'm not going to sit and read out the entire slide for want of time because we've already taken a lot of time to address basic issues. I'm going to cut to the chase and say that this history is very much suggestive of a painless mid-trimester loss. Okay, this is a classic history of a painless mid-trimester loss, which has been taught to us since undergraduate and postgraduate years. I will not insult your intelligence by asking you to identify what this is. But what I want to ask Dr. Shazia Monis is, how will you treat this lady? How will you investigate her? And what treatment do you suggest for her when she gets pregnant again?
Sir, actually, going by the history, the diagnosis of cervical insufficiency is usually clinical, but it is usually a retrospective diagnosis. And the best way is to proper history taking and examination and by transvaginal ultrasound. Transvaginal ultrasound, if she conceives next, then of course we will find the finding are the cervical length is less than 25 millimeter. There is funneling of the os. And if she conceives for the third time, I won't take any risk. If I find that the cervical length is less than 25 millimeter, I would advise her cervical encerclage. Usually we go by the vaginal route and abdominal encerclage we do once the vaginal cerclage fails or there is gross disruption of the cervix to allow the vaginal cerclage. So in this patient, if she conceives for the next time, I would advise her cervical encerclage if the cervical length is less than 25 millimeter, after ruling out all the contraindications of cervical encerclage. Now, patient will ask me at what time of gestation you will do the cerclage. So I think the best time is between 12 to 16 weeks of pregnancy. It is the best time to do the cerclage after ruling out the contraindications of cerclage.
Thank you very much. Yes, please go ahead, ma'am.
Yeah, this is very clearly history indicated cerclage, then which is little done very early, 12 to 14 weeks. When it is an ultrasound based screening in high risk cases, or when there is, uterine malformations or a septum resection and all that, when we are screening ultrasound wise, then we do generally have it at a later stage. Whereas the third thing is the physical examination indicated cerclage is generally an emergency situation. So that is one thing. And then the level of cerclage, McDonald's and Shirodkar and all are little high cerclages for very clear cut indications, technically difficult. And then abdominal for, when we don't have even lips of cervix or even length of cervix to do it from below. So that's how it goes. But yes, but with progesterones and the incidence and the use of cerclage has come down a lot. That's what I feel in my this thing. We used to do it for all.
It's becoming a lost and dying art.
Yeah, but definitely when there is history indicated and when there is a history of previous encerclage, the patient has had a successful pregnancy. Like she has had 2 abortions, then she had a cerclage. Now she has come to you. Now it is very difficult to refuse. So these are few conditions where I go for cerclage. Instead of counseling the patient in a negative way that you don't need a cerclage, because the risks of cerclage are also not less. So you have to pick and choose. The indications are coming down.
I would like to add one thing, ma'am. If the cervical length is less than 25 millimeter, then we can go in for cerclage. And if it is more than 25 millimeter, then of course we can keep the patient on progesterone.
Yeah, again, Shazia, if it is only ultrasound based short cervix length, we can as well go for a progesterone. If it is the preterm risk that we are thinking of, both options. Either if it is history, only history is there, we can go for the studies are with injectable progesterone. If it is with ultrasound short cervix, the very good studies are there with micronized progesterone. But if patient has had previous cerclage or if there is very clear-cut history indicated, you can, yes.
If there is no short cervix, but the opening of internal os is started in sonography, then we must go for the cerclage. It is not
here. I think it's very clearly mentioned that there is a history of painless mid-trimester losses. Rather than progesterone, we would justify the putting in of an encerclage. What I want to ask Dr. Jyoti Saigaonkar is, being a Mumbaikar, do you prefer the foreign McDonald procedure, or you are an Indian, a Mumbaikar, and want to do a Shirodkar?
Forever for a McDonald's.
Always a McDonald's?
Always a McDonald's.
The studies have shown that the results are the same of McDonald's or Shirodkar.
I think there are very strong proponents of Shirodkars. Seniors
maybe, and also we, Pratik, as you very well know, Pratik was my registrar, and we have not, I have not been trained that well in Shirodkar during my residency days. One of the reasons maybe,
This is exactly the point that I was trying to bring out, that in spite of hailing from Mumbai, studying under the same people who probably are second generation after Professor V.N. Shirodkar, we ourselves still are not confident of performing a Shirodkar cerclage, which means that this procedure is dying. We need to practice it more frequently. We need to propagate it. We need to train our juniors. And we should ensure that this art is not lost, because this is one of India obstetrics gift to the world. In fact, if you look at the most recent RCOG guideline on preterm labor and birth, part of which Dr. Kiranmai quoted just 2 minutes ago, that it is now considered that vaginal progesterone and cerclage are equivalent. Okay, for the first time in 30 years, the RCOG has now come down from its throne and is saying that you can do a cerclage. It is also an effective procedure. Previously, they used to always say, no, cerclage is something which was born in the colonies. We don't favor it. It's not something which we should advocate it anymore. So this is the take-home message, that in a patient where there is a clear-cut history, there is the strongest indication for cerclage. ultrasound indicated and rescue cerclages, the questionable indication are present. But I think these patients where there is a clear history, you will have the maximum success. And please, in these patients, advise them properly and guide them in the right fashion. In fact, in our Foxy Current Updates last year, where Dr. Nandita Palchetkar was president, we highlighted this particular guideline. I don't know if you received this. Let's go to the next case. This is a lady who has PCOS, anovulatory infertility, weight is 100 kilos. She has had 2 miscarriages. This is an endocrinopathy. This is different from the previous 2 cases. The first was maybe a genetic cause. The second was an anatomical cause. This is an endocrinopathy. I'm going to ask Dr. Dibyendu sir, what is your experience of patients who conceive with great difficulty after having PCOS and then land up with recurrent miscarriages? What should you offer them to give better results? Is Dr. Dibyendu there?
Sir, unmute, sir. Yes.
I didn't get
Unmute,
a
sir.
question. Yeah. I didn't get a question. Yeah.
The question is, this is a lady who is 100 kilos in weight. She has conceived with great difficulty. Typically, PCOS patients are very resistant to treatment, and she's had 2 losses. Now, when she conceives, what changes would you suggest? What treatment would you institute to ensure that this pregnancy goes to term?
Yeah. First of all, I would tell her I would have been happier if you had come to me before. Not with this. Basically, these are the patients where maybe metformin has got a role. We need to do a glycemic index. We need to see where she stands, as whether she's euglycemic or she's got after an OGT, whether she's in the high risk for developing diabetes. There is definitely a role of starting aspirin at the earliest, and I'm not very much in favor of using any steroids, and this is because she is already pregnant. If she had come to me before she was pregnant, I would have definitely advised her a very stringent diet and a workout session. If it had not worked, if she's 100 kgs, maybe if she's resistant to exercise and diet, I would have advised her some surgical measures maybe, and to have checked her before regarding her glycemic status. If she's come already with pregnancy, I will start her with aspirin, maybe start a metformin and start a progesterone.
So in an ideal world, you would like to offer her aspirin, metformin and progesterone. I think all of these 3 are evidence-based, and Dibyendu sir is absolutely right there. What I want to ask Dr. Jyoti Banglowala is, Madam, what is the right time to start aspirin? Before pregnancy, during pregnancy, at a particular stage during pregnancy?
Many cases like this PCOS girl, and the BMI is more and the weight is 100 kg. Most of the time I start aspirin pre-pregnancy in the low dose, the 50 to 100 milligram per day. If the patient is willing and patient is coming for the counseling for pregnancy or premarital counseling or pre-pregnancy counseling, if the patient comes after 1 or 2 pregnancy losses, then I will start them 75 to 150 milligram aspirin per day. Most of the time I do this.
So most of our textbooks say you start aspirin when you see cardiac activity at 6 weeks. This is what the textbooks say.
There is a change in thought.
That is what I'm trying to bring out. That is what I want to bring out.
Green Talks guideline of 2011. This says that we can start aspirin before pregnancy also, and just after the urine pregnancy test gets positive, we can start aspirin. But the timing must be in the timing of aspirin giving is the judicial.
So I think this is the change in practice that I wanted to highlight, that though our textbooks say you start it at 6 weeks when cardiac activity is seen, by that time a lot of issues which we would miss have already been instituted. Therefore, many of us who are in ART practice actually start pre-pregnancy itself. And regarding the correct dose, I don't want to start the controversy. I think it is well known. Most
at 100 kgs, in a patient of 100 kgs, I would prefer to use 150.
Absolutely. That is the point that I was trying to bring out. Let's go to Dr. Vidyalakshmi. She's been quiet for quite some time. I want to ask her, what is your take, ma'am, on the role of insulin sensitizers in PCOS and a reduction of miscarriage risk very specifically?
So while metformin itself, I think it has a very good role in preventing the RPL in patients with proven insulin resistance. So,
Okay.
but in cases, universally giving for all obese women, I don't think that's the way we should go about it. Should be in patients, probably check out the insulin levels, fasting insulin levels. If they have proven insulin resistance, previous history of PCOS as in this patient. So in such patients, I think it's a good option to start metformin. But other insulin sensitizers, there are lots of studies, but I would not completely go with those.
Dr.
Using
Shazia?
monoinositol, dechiroinositol, yeah, they are being promoted in pregnancy, but I'm not very certain about the usage in common parlance. Universally, I would not start.
Dr. Shazia, what is your take on this? Do you think that metformin and insulin sensitizers help to reduce the risk of recurrent miscarriage in patients with
Yes,
PCOS?
metformin has a very good role in reducing the risk of miscarriages because the basic pathology is there is hyperinsulinemia, hyperandrogenism. Plus, in PCOS, there is one more problem. There is there is fibrinolysis also. So metformin, what it does is it reduces the hyperinsulinemia, hyperandrogenism. It reduces the insulin resistance. Plus, it also reduces the plasminogen inhibitor activity. So it reduces the chances of thrombus formation and increases the blood circulation. So in patients with RPL, metformin, I will go for giving metformin.
Okay,
Because it also
so
reduces the resistance.
if I may summarize what has been said so far, everybody is in favor of giving metformin and insulin sensitizers in patients with PCOS with a view to reducing risk of miscarriage. You'll be very surprised to know that while metformin is highly recommended in PCOS patients for all the reasons which were listed out in the previous slide, unfortunately, as far as reducing the risk of miscarriage is concerned, it is as yet
That's what it
unclear.
is.
There is no
And
clear evidence that it reduces miscarriage risk.
can I add one little
Yes, ma'am.
point?
Yes, ma'am.
As you said, theoretically, it is really, I mean, the role is very much. But as you have said, the evidence that it reduces RPL is still not clear. And also the investigations, the insulin levels and plasma insulin to glucose, all those investigations are also not advised according to the HRA, which are not beneficial. That's what the latest guidelines says. I think.
Absolutely. So this is what the theory is. If you ask me what happens in clinical practice, what happens in clinical practice is often not evidence based. We go by experience based and we go at spinal level. For example, those of us who practice ART, typically such a patient would already be on metformin before she conceives also. And in pregnancy, we normally recommend that the patient continues metformin at least for the first trimester. But, and this is a very important caveat, that in theory, it does not reduce the risk of miscarriage. Please remember this. We are giving it for this indication, but the evidence does not bear that out. Maybe 5 years from now, we'll have large population studies which will turn this entire theory on its head, and we'll find that what we were doing out of experience, out of our gut feeling, is actually proven right. So, this is the important distinction that we have to understand. When it comes to corticosteroids, the evidence is even more confused. I'm going to ask Dibendu sir to elaborate further. He started this discussion, so I would like him to elaborate further. Do you think steroids have any role at all, or is there any class of patient who has RPL who would benefit from steroids? Let me ask it this way. Sir, you're muted, sir.
Yes, muted.
Whatever the studies show, or if you go through the review of literature, there is no definite benefit of using corticosteroids. And we all know that the long-term use of corticosteroids is associated with certain fetal defects, maternal morbidity. So it is always better, until and unless we have clear-cut guidelines about the use of corticosteroids, it is better to avoid it. Of course, if the patient is suffering from some autoimmune disease like SLE, etc., there you've got to use it. But those are exceptions.
So I think sir has rightly pointed out that in vast majority of cases, corticosteroids during pregnancy will not improve live birth rates as compared to aspirin and low molecular weight heparins. As he rightly pointed out, often there is a question mark regarding their safety during pregnancy, and congenital anomalies can be there. Having said that, in recurrent implantation failure, which I feel is a subset of patients with recurrent pregnancy loss, you will find that sometimes addition of steroids does help. To quote, there
Yeah,
are these studies.
that is because that it reduces the inflammation at the level of the endometrium.
Natural killer
True.
cells, I think.
Natural killer
Residual
True.
natural killers.
True. And you will see that your implantation rates increase from 6% to 21%, and your live birth rates increase from 3% to 23%, which is a huge increase. But these are small studies, these are not large population data, and therefore we cannot extrapolate these results into the larger population of recurrent pregnancy loss. This is not an evidence based universal recommendation for everybody. In small groups of 160 patients, they found that there are ongoing pregnancies of 70% compared to placebo, where there is 91% miscarriage. So, it does have some role to play, but as yet unclear, and probably we will have more elucidation in the times ahead. I'm going to ask Dr. Shazia Monis to comment a little bit about bariatric surgery. It seems to be very popular in Bollywood and in the North, two very distinct subsets of Indian population. Can you comment a little bit about bariatric surgery?
Yes, sir. In India, it is yet to come up with bariatric surgery, and yes, I have seen good results with bariatric surgery in patients who are having BMI more than 35. And yes, of course, it has good results. And of course, besides weight loss, there is reduced insulin resistance. With the weight loss of the patient, there is improved insulin resistance, and yes, it has good results.
So, if you have a BMI which is more than 35 or 45, patient is refractory to treatment, patient is not responding to anything else. She has gone through the entire gamut of weight loss, insulin sensitizers, repeated miscarriages. Then maybe you could consider this as one of the last options.
The catch line is when all other modalities.
Absolutely. It's not a primary modality to be offered. Having said that, Dr. Jyoti Saigaonkar, any experience with bariatric surgery practicing in Thane?
No, not in practicality, but I have spoken to a lot of bariatric surgeons who all the way, recommend ki, all your infertility patients who are willing to conceive, and you have a time frame within which you have to make them pregnant and, have an ongoing pregnancy with a live birth. It is better to go in for a bariatric surgery. But as sir very well said, that only when all the other options of diet, exercise, and a correct lifestyle fails, that is when you would recommend.
Actually, here we are inserting gastric balloons in such patients, not doing the clear-cut bariatric surgeries.
Correct. But having said that, it is recommended as a primary modality only for patients whose BMI is more than 50. And for HFA guidelines, it is a BMI more than 40. Even the most recent ESHRE SRM guidelines
If the cutoff age is going to be high, if the age is going to be high and the patient is having very less years of fertility, then we go for this surgery.
True. So there are a lot of caveats, and we've already discussed that. Let's go to the next case. This is a spot diagnosis. She has had 2 losses. Both are first trimester losses. This is the ultrasound picture. I'm going to ask Dr. Jyoti Banglowala to comment on this and take us forward.
This is a septate uterus, didelphys, and the patient is a
septate or didelphys?
Didelphys.
Didelphys? Septate? How can you be sure?
No, septate.
Hysteroscopy.
How can you be sure? Which is which? What would you do to confirm?
I will go for the TVS 3D TVS USG.
This is 3D TVS picture, ma'am.
Yeah.
I'm going for the.
And I think MRI is a better option along with the HSG.
HSG is now, he said, now routinely he is not doing HSG.
So if you want to see the fundus properly in a non-invasive fashion, sometimes 3D ultrasound and 99% of the time MRI is supposed to be the most sensitive and specific investigation. But I don't want to get into that controversy. What I want to ask is, how will you treat this condition? Let's cut to the chase.
Do a hysteroscopic resection. This is
Hysteroscopic resection is hysteroscopic
septum resection and plasty.
Okay.
Hysteroscopic results are good.
What do you need plastic?
Septum.
Can somebody tell me how to do a hysteroscopic resection? Anybody, it's open to anybody. Anybody who has experience in doing these can comment on this for the next 2 minutes.
Sir, I have watched resection. Yeah.
Yeah, go ahead.
You can.
A hysteroscopic resection with a monopolar or a bipolar resectoscope is the gold standard. If you use a monopolar
how would you
current,
do it? Yeah, go ahead.
yeah, if you use a monopolar current, then glycine is used. If you use a bipolar current, then normal saline or ringalactate is used. And you can do it with a pair of scissors where electric, current is not used. That is more safer. But if you have a thick and broad septum, that is the place where, resectoscope plays a role. So you can use a loop, or you can use a hook or a loop, and you can resect the septum under hysteroscopic guidance with a laparoscopic.
So if I may be permitted to ask, what is the difference between septal incision and septal excision? Are they the same or are they different?
No. Septal incision is, they are different. They are different.
So please tell us, what is the difference?
For excision, you underdo this thing. Once you reach the fundus, you don't get into the fundus to remove the base of the septum, which is much more risky. So in excision, maybe we underdo. In cases of incision, you cut into the fundal this thing and remove it. And in that case, there is a chance of a perforation. And in that case, you make the fundus weaker in the long run.
So I think the simple theory is that if it's a large, big septum, which is fibrous, which is going to be a residual stump behind, then you go ahead and excise it by shaving from both walls and excise that small little chunk. Of course, that's only a theoretical concern because the vast majority of patients don't have this large, big, complete septum. Yeah. But there are occasional patients where you will see this.
Scissors suffice in most of the cases.
Yeah, and you have to be prepared to tackle them, and you won't be able to tackle them unless you have investigated properly and appropriately prior to taking the patient up for surgery. You can't put in your telescope and say, "Arey, itna bada septum hai, abhi kya karenge?" That is not pardonable on your end, my part. And earlier I showed one little classification diagram, which is the ESHRE and ESG classification. All of us should be following this now. And there is a standard documentation form which ESHRE has come out with, which looks at uterine, cervical and vaginal anomalies all on one single page. I would highly recommend that all of us start using this if we are not using it in clinical practice, because we talk about diadelphys, we talk about septate uterus, but we often neglect to mention what is the cervical and vaginal formulation that we see. The other anomalies are often missed out. I'm not going to do this fifth case because of lack of time. I'm going to go straight to the sixth case, which is Apla syndrome. And I'm going to ask Dr. Kiran Mai to comment on this. This is a lady with proven Apla syndrome. How would you approach her? And what would be your therapeutic options that are available to you?
This is one of the conditions which has a very good treatment and response options in RPL. Should be happy if the diagnosis is applied, right? So one is the anticoagulant is little borderline, but glucose anticoagulant is positive. So we have to put her on anticoagulants. One is aspirin, which we can start very conceptually, and then low molecular weight. Right. So I say again, it is 150 maybe, and then low molecular weight heparin, about 40 milligrams subcutaneously once daily. Then the definition criteria is, as I've said, one is laboratory, the other is clinical. Clinical is, now it is 2, I think, not 3. ESHRE about ESHRE says 3 early losses, then at least one loss, only one loss with less than 34 weeks with preeclampsia or any other associated features of preeclampsia. Then 2 or more losses at more than 10 weeks after documentation of fetal cardiac activity. Either one lab, and the lab is anticoagulant antibodies, IgG and IgM. then antiphospholipid antibodies, and beta-2 microglobulin. These are the 3 lab criteria. So 1 lab and 1 clinical. There goes the diagnosis of ACLA. So again, if they have no other, one is obstetric primary, that's only obstetric complications are there, and then others which you have had previous vascular thrombotic episodes, then again the anticoagulation differs here. So you go to the therapeutic levels of anticoagulation if there is previous episodes of thrombotic episodes. Otherwise, they go on the prophylactic. Anything else, Dr. Pratik? And then we have to continue at least till 36 weeks if she's on heparin. Then we have to stop heparin at around 36 weeks and then switch over to unfractionated heparin. Again, stop at around 12. If it is a planned induction, then we have to stop before 12 hours. Otherwise, as soon as labor is established, then we have to monitor. If it is only prophylactic dose of enoxaparin, then there is no need to monitor platelets and all. If it is therapeutic, again, if it is enoxaparin, there is no need. But if it is unfractionated heparin therapeutic, then we have to monitor on platelets. Then some people do recommend a factor 10A monitoring also, if it is therapeutic dose of enoxaparin. Then again, after delivery, we have to re-establish the anticoagulation, that is heparin, after 12 hours. Then 6 weeks. If it is only APS, obstetric, then it has to be continued till 6 weeks. Otherwise, if it is therapeutic with other indications, she has to continue as per this thing. So then primary and secondary with other SLE and all. Here, I would just take half a minute to share one case of recurrent pregnancy loss who did not fit into any of the criteria. She was also having pancytopenia. And thrombocytopenia. So we estimated B12 and folic acid. She was found to be dimorphic anemia with low levels of B12 folic acid. And after which the hemoglobin improved, but the platelets did not improve. So again, we went further with theoretical interest, and our anti-nuclear antibody was positive, strongly positive. So she was started on hydroxychloroquine and also isonone steroid, with which dramatically her platelets had improved, and she has carried till term and had carried home a live grade.
Probably she was not a pure APLA. She was one of those mixed connective tissue disorders.
Yes, connective tissue disorders. The other day I was listening to Mala ma'am, as you have said, in the future maybe ANA will come into the battery of tests of RPL. That's what she was prognosticating. ANA, though it is at that time it didn't fit into the obstetric kind of presentation. Yeah.
So typically these myelofibrosis and myelodysplasia, they are also associated with and masquerade like APLA. But when you describe pancytopenia, it looks like a bone marrow disorder. Thank you so much. I'm going to ask Dr. Dibyendu sir, do you have any experience with this unfractionated heparin? Have you given this?
Not really.
You've completely switched over to low molecular weight heparins. You find patients are much more happy to use it. They are happy to self-medicate on their own.
Yeah. Not only that, I would be on the safer side by using low molecular weight heparin. Given unfractionated heparin, monitoring the patient, and then thinking over of switching over at the end, it's much more cumbersome. For the private practitioner, I would always prefer a low molecular weight heparin.
Thank you, sir. And in your experience, I think Dr. Kiran already mentioned, but how early would you like to stop prior to intervening with a cesarean? Do you find it makes a difference whether you stop it 24 hours before, 48 hours?
Ideally 24 hours. I'm happy with 24 hours. I even if these patients have come to me with a membrane rupture, receiving on heparin, mainly because it was advised by IVF people. We've done it. It doesn't make much of a difference. 12 hours is fine, but ideally for 24 to 48 hours is the best time.
And are you worried about reactionary or secondary hemorrhage in these patients when you do a cesarean?
Not really.
So how soon after the cesarean would you restart? This is a practical question. Often we keep getting asked this. Doctor, ये injection वापस चालू करने से bleeding होगा क्या?
नहीं कुछ नहीं होता. 8 घंटे के 6 to 8 hours you can start happening.
Okay. So probably within the first 24 hours, if there is no issue, on the next day or no morning rounds, you can probably restart it. And the good part is that we don't need PTTK. There's no need for monitoring.
Monitoring.
And even the hematologists are very happy because we don't keep calling them and asking them to adjust the dose of heparin. So they have actually been the most happy and contented people once this particular formulation has come out. I think we're out of time. There's a huge amount that we could have discussed today, including recurrent implantation failure. We briefly touched on it. Thin endometrium, tuberculosis, immunotherapy, gene therapy. There are so many new advances which are coming into this huge armamentarium that we have for gene therapy. But I think it's important for us to reiterate and remember that finally your role as a physician, as a confidant, as a father figure or a mother figure, as the case may be, tender loving care, appropriate guidance in a timely fashion is of paramount importance in this entire class of patients, because more than 50% of them are so-called, in inverted commas, unexplained infertility. And I'll close by saying that there is some good in this world. It is worth fighting for. I thank all of my panelists for a fantastic panel discussion. We gave a lot of take-home messages while we were here. And I would like to request all of our panelists to give one small take-home message for the audience before we hand over to Charmila for the formal vote of thanks. We'll start with Dr. Dibyendu.
First of all, I'd like to thank Pratik. You moderated an excellent panel. Your questions, your case selection was immaculate. The message here is maybe we surely need to cut down to 2 recurrent pregnancy losses for RPL. Treating a patient before conception is ideal, and it is always that we should send a positive message to the patients. They are already stressed out. We tell them, even if you do nothing, you've got a 50% chance of going forward with a normal pregnancy. That is it. If that much a positive message does wonders for your practice.
Thank you, sir. Dr. Jyoti Banglowala, ma'am.
Yes, first of all, I want to give you a big thank you and Charmila for making me the part of this wonderful panel. But I think the loss of baby is the loss of hope. So most important thing is a better understanding for the couple as a whole, not the female only, male partner also.
Right.
And the proper counseling, and then the treatment part begins. So
Thank you so much, ma'am. There are over 700 viewers still tuned in, and they want to know what Dr. Shazia Monis has for them.
Okay, thank you, Dr. Pratik and Dr. Charmila ma'am, for including me in this panel and including me in this learning process. I think pregnancy loss is a significant negative life event, and recurrent pregnancy loss intensifies the grief experience. We should consider the psychosocial needs of the couple faced with recurrent pregnancy loss and give correct information, and we should avoid unnecessary investigations and review the history, plan the investigations, and then we should plan the treatment, or not give them a list of investigations every time. And we should individualize the case according to the age, family history, the fertility history, and the previous steps. And in the last, I would say all they require is tender, loving care and lot of psychological support besides the investigation.
Thank you so much, ma'am. Dr. Vidyalakshmi, ma'am.
What can I say more than the seniors have?
Yeah, same.
I've been thinking, racking my brains. What do I say differently? So there's nothing different. Same thing, sir. Basically, we just need to tell them that there's a cup half full. It's not always half empty.
Yes, and the cup is refillable.
Yeah, it's always there. So the future is infinite. There's a lot of options. A lot of hope is still there. So nothing is lost. There's a great future ahead of everybody. So this is all I would say to my patients. Of course, like Madam said, we have to individualize our treatment. We can't just say unnecessary investigation. What's unnecessary to me might be necessary to somebody else. So let's individualize the treatment to each and every patient. And that kind of tailoring should be more than enough. More than anything, if we don't do anything, if we do not do anything harmful, that's more than enough. So do no harm.
Absolutely. Do no harm first. Dr. Kiranbhai, ma'am.
Yeah, I would not like to repeat what has been already told, but vitamin D, B12, lifestyle changes, TLC, and then over investigation. I have seen one patient where she had 2 abortions and the whole thrombophilia screen without any proper indication. And then polytherapy also just like that for each and everyone also. We need to update and learn because it's a very fast changing subject, and then that's it. And thank you, Pratik. Thank you, Charmila. It was a wonderful session.
Thank you so much for gracing the occasion, ma'am. I think you had an emergency surgery, and in spite of that, you still managed to come. Thank you so much. Really appreciate it. Yes.
Yeah, thank you.
Dr. Priti Saigaonkar, some words of wisdom from you, ma'am.
I think all the speakers have so well said, and I would like to thank Dr. Pratik first of all to for giving me this opportunity to be a panelist on this session. And I would just say one thing: let's spend time in counseling for the first 2 to 3 consultations. Now, spend time in counseling, give time to the patient, win her trust, and then go ahead with the treatment in the individualized form. So I think once you get her trust, things get very they ease down a lot, and you can manage the patient much better.
Thank you so much, ma'am. Thank you. So a big thank you to all of the participating societies and the office bearers from Dindigul, Tirunelveli, Pondicherry, Tirunelveli. Thank you everyone who has tuned in. I've been told that we have more than 700 people who logged into today's webinar, in spite of it being an afternoon event, which generally has lower attendance than the evening events. And I think that is testament to Dr. Charmila's leadership skills in bringing everybody together and getting all those presidents and secretaries from the societies which are so reclusive to get them to participate, make them open up, talk to us. And of course, we have to thank Science Integra, our backbone, Subbu, Seshan, Shrimon, thank you so much for everything always. And our academic partners, Bharat Serums and Vaccines. For the formal vote of thanks, I would like to hand over to my co-convener, Dr. Charmila.
Thank you, Pratik, for a wonderful session. I know the entire South must be enjoying the program, and these webinars are actually a boon now because we get to hear from so many people across the country at one point of time. I would like to thank Dr. Nandita Madam, the President of AMOGS, Dr. Arun Nayak, the Secretary of AMOGS, the AMOGS Endocrinology Committee Chairperson and the convener, Dr. Pratik Tambe, for a wonderful program. I don't know where you get that energy to do programs day in and day out, but it's a great credit. And doing it as a committee chairperson and you're continuing after being a FOXY chairperson is a great thing. And we would like to appreciate all that work you're doing and all the coordination you're bringing into different parts of the country. And I would like to thank the President and Secretaries of the Dindigul Society, Karimnagar, Puducherry and Tirunelveli societies, the chairpersons who grace the occasion, Dr. Parag Biniwale, Dr. Arun Madhav, Dr. Amala Devi, Dr. Madhavi and Dr. Pushpa. I'd like to thank the panelists, Dr. Kiran Mai, Dr. Vidya Lakshmi Pradeep, Dr. Dibyendu, Dr. Jyoti Banglawala, Dr. Shazia, Dr. Jyoti, and the wonderful talk given by Dr. Sujata Dalvi, Madam. I would like to thank Madam for that. I'd like to thank the coordination of this program by Science Integra, especially Shrimon, as well as the other coordinators, Subbu. And I'd like to thank the sponsors, Bharat Serum and Vaccines Limited. Thank you so much for a wonderful program. It's a great privilege that you had the prestige of coordinating such a big program with so many societies and such great panelists also. We could hear the discussion going on in the panel and each of you gave wonderful points. Thank you so much for all that.